Wait. 1 second. I'm giving her. Speak.
बहुत ऊपर है. Attention please. On behalf of Science Integra, I, Pragya, extend a warm welcome to one and all present here. I take all pleasure in welcoming our host, comparer for the evening. We have with us Dr. Aditi Tandon. She is a budding OBGYN from Foxy. She practices in Mumbai and is a well-known figure in social media. May I now request Dr. Aditi Tandon to take the proceedings of the event further. Over to you, ma'am. May I have a round of applause for her?
Thank you, Pragya. Good evening, everyone, and welcome to the inaugural meeting of the Osteoporosis Society of India. I'm truly honored to lead this session as we embark on a journey to shine light on a condition that affects millions, yet remains largely in the shadows. Well, for starters, I have a lot of bones to pick. As doctors, we understand that healthy bones involve more than just drinking milk for calcium. But does the common man really know that? Today, discussions about diabetes, hypertension, and even obesity are common, yet osteoporosis hardly gets a mention. This gap in awareness is striking and needs our focused attention. I believe that to some extent, we share responsibility for this lack of conversation. However, I'm genuinely optimistic that we can change that narrative. Most of us are active on social media, especially when it comes to women's health. For instance, I've made a few short videos on Instagram about osteoporosis, particularly highlighting its association with menopause, the risks of early menopause, and the critical role of weight training for women's bone health. Admittedly, this probably represents just 1% of my overall message on social media, and I suspect that might be similar for many of our peers. While topics like fertility, sexual health, PCOS, weight loss, even endometriosis are frequently discussed, conversations around osteoporosis and even menopause beyond the lens of fertility remain scarce. Well, if bones were visible on Instagram filters, maybe we'd have more awareness. Our generation has embraced digital platforms, and many gynecologists are sharing vital information. I'd like to give special recognition to Dr. Nandita Palshetkar for her outstanding efforts in raising awareness on women's health online. Your work inspires many of us and sets a benchmark in digital health communication. Welcome, madam. On a related note, I've noticed an intriguing trend. Why do we see fewer orthopedic specialists on social media? And broadly, why aren't there more women orthopedic surgeons sharing their expertise? These are important questions as they touch upon not just content, These are important questions as they touch upon not just content, but also representation in our field. They say that what you don't know won't hurt you unless it's osteoporosis. Then it might literally break your back. Today marks the beginning of the Osteoporosis Society of India, one of the first multidisciplinary national bodies on this condition. Osteoporosis isn't solely the realm of the orthopedicians. It is a challenge that also concerns gynecologists, endocrinologists, and other specialists. This integrated approach is essential for driving forward meaningful change. A big thank you to Science Integra for their initiative in establishing this society. Their vision, coupled with our collective expertise and dedication, will pave the way for innovative solutions and broader outreach. Today, as a united community spanning various specialties, we have the power to change lives. Let's embark on this journey with enthusiasm, collaboration, and a commitment to making osteoporosis a topic that deserves and receives the attention it truly warrants. Let's not just diagnose fractures, let's prevent them with awareness, access, and a bit of bone dry humor. Thank you, and let's make a difference together. It is my privilege to invite our first speaker on stage to give the welcome address, looking at the existing science on osteoporosis, Dr. Nandita Palshetkar. She is founder and member and medical director, Bloom IVF, renowned gynecologist and IVF specialist with 30 plus years of experience. She's helped over 25,000 couples achieve parenthood through advanced fertility treatments. She's received various awards like the Bharat Gaurav Award by House of Commons in UK, the Golden Globe Tigers Awards, Malaysia, multiple Lifetime Achievement Awards from various associations. She is past president FOXI, ISAR, AMOGS, IAG, and currently FOXI representative to FIGO. She is also honorary professor at DY Patil, and she's a postgraduate teacher at MUHS Leelavati Hospital. She's also a great mentor to all. Welcome, madam.
Good evening, everybody. Dr. Sushruth, your dream has finally come true. I think he is so dedicated in the field that he really wanted to start this society, and we worked together before. And it's something that he spoke about so passionately, and I think that's how everybody has got together over here. And so I'm really proud to announce the launch of this association. This is something which the people of our country, I talk for the women, the men of our country really need. It's a very silent but a terrible epidemic. And I think as Dr. Babalkar used to always say, that there are multiple faculties which are treating this. But we need something, a common consensus, a common ground where everybody can work. And I think I must thank Science Integra, Subbu, for actually, converting this dream into action. I think it's amazing. Like-minded people have come together and it's there. So I'm really happy today to be here and working with Dr. Sushruth, because his passion is unparalleled. And today, a lot of my mentors are here, Dr. C.N. Purandre, Dr. P.C. Mahapatra, Dr. Saraya. I think I've worked with them. And of course, a lot of friends are also here. So let me begin by an introduction to the Osteoporosis Society. What is the existing science? What is the mission of this association? I think we've all got together to advance the science, awareness, and management of osteoporosis in India. And I think it's very important because we need to understand that we have a disability-adjusted life years. This is the study which was done, and this is the 2025 data, which actually shows that India has the highest rate, one of the 5 countries which have the highest rate of osteoporosis. So, yes, we know we all do BMD, it's part of the health checkup, and a score of minus 2.5 at different bones are checked, and that diagnoses osteoporosis. I mean, if you look at the existence, the incidence of osteoporosis, it's 24.7%. It's very, very high. In fact, infertility is at 17.5, and WHO has flagged it off that we have to look at it. And I'm sure soon osteoporosis will also be something that WHO will look into so that it can, help and start programs. Prevalence in women was 15%, out of which 10.3 was in the postmenopausal women and 4.7 in the premenopausal women. And prevalence in men was 9.7%. So, I think looking at the challenges that we have seen, of course, the screening thresholds are there. In 2025, US actually published guidelines which were not very different from the 2018, but they added a few things like clinical judgment. It's important. So highlighting the need for better risk assessment tools, especially for men and younger population. And WHO has come up with a risk score which tells you in 10 years what is the chance of your fracture, and you can go online, access the tool, and actually put in all the details. So FRAX score, which is there, and secondary causes. So in younger postmenopausal women, it is important to individualize the risk. India must adapt these global insights to its unique epidemiology. We all know there is a study which says that Indian women age 7 years faster than their Caucasian counterpart. And as a gynecologist, as IVF specialist, I see at least 30% of my OPD is women who have reduced ovarian aging. And we really need to look at that. Vitamin D deficiency, 10 years ago when we really, 15 years ago, we started doing it, 90% of the women who came to us were vitamin D deficient. But today the scenario has changed, the awareness, a lot of programs, and I think people are taking care of the vitamin D, but it still exists. I think it's about 40%, I feel that the incidence is there in our private practice. While addressing the gaps in screening and access, I think, yes, there is a question, rural DEXA availability, but there are ultrasound machines where we do camps, we go to the rural areas, and we can actually find out what is the incidence of osteoporosis. So not only is it difficult to clinically predict osteoporosis risk, the fragility fractures which occur even without osteoporosis. In Jan 2025, researchers published a randomized placebo-controlled trial for an alternative strategy for reducing fractures, that is treating women in early menopause with anti-resorptive therapy regardless of the bone mineral density. So what are the latest developments and challenges in osteoporosis diagnosis and treatment? Capturing the latest development and challenges in the osteoporosis diagnosis and treatment. If you look at it, updated clinical guidelines, we really need that to cover new recommendations from various organs. So this is what the whole aim is, that we all get together and have a common SOP. That is very important. Anabolic agents, these bone-building agents, are now being used more widely in treatment. FRAX and FRAX Plus updates, improved tools for assessing fracture risk. Adjunctive diagnostic tools, trabecular bone score, helps in diagnosis osteoporosis and predicting fractures. Special population, I think we need to focus especially in spinal cord injury patients, chronic kidney disease patients, and the premenopausal patients. The rare side effects of the management covers osteoporosis of the jaw, atypical femur fractures, rebound fractures after stopping denosumab. So I think these are some of the rare conditions which we need to handle also. So a way forward in this challenging scenario of osteoporosis diagnosis, treatment, and management. Professional development and education, providing CME to keep doctors updated on the latest research, treatments, and guidelines. Organize, this is the first conference of the Osteoporosis Society. So workshops, journals to share knowledge, setting standards and guidelines, develop evidence-based clinical guidelines to ensure best practices in patient care, promote standardized protocol, advocacy and policy influence, advocate for patients' rights, healthcare policies and funding for research, who work with the government, regulatory bodies to shape healthcare laws and regulations. Of course, research and innovation is very, very important. Networking and collaboration. I think this is one of the examples of networking and collaboration. Multidisciplinary teamwork is really required. Patient care and public health. Improve quality of care by reducing variations in treatment. Raise public awareness about diseases, prevention and treatment options. And finally, addressing rare and emerging issues. Study rare diseases and complications, as I mentioned before, and develop specialized approaches for unique patient groups, osteoporosis in spinal cord patients. So friends, looking forward to a great journey in advancing the management of osteoporosis in India. Thank you. Thank you very much.
Next is, yeah.
Our next speaker for the first keynote is Dr. C.N. Purandare. Welcome, sir. He has over 40 years of experience in women's healthcare, former president FIGO and FOXY, emeritus deans ICOG, honorary professor at Grant Medical College and JJ Hospital, awarded the Dr. B.C. Roy Award for Medico-Social Contributions, honorary fellow of RCOG, FRCPI and FACOG, consultant at Purandare Hospital, Saifi Hospital and others in Mumbai, part of the Purandare legacy in women's health spanning over a century. Welcome, sir. He will be speaking on what do we think of osteoporosis management today.
Good evening, everyone. We are already delayed today with the airlines contributing to it by some of our delegates who have arrived late. I managed to get out of Delhi in the morning, so I was okay. Those who started in the afternoon, with the traffic, etc., everything has delayed. Anyway, all the same, Nandita has more or less covered everything that needed to be talked about when you're talking about the osteoporosis and the advantages. So what do you think of the osteoporosis management as far as the obstetrician gynecologist is concerned? And we must understand something, that the calcium reserve and the vitamin D need starts from childhood to adolescence to pregnancy right up to menopause. And this is not something which is a problem which we are going to face at the age of 50 when women are closer to menopause and we deal with them. It has to be looked into in a holistic approach right from the beginning to the further on in life. So what do we think of osteoporosis management as far as obstetrician gynecologist is concerned? The osteoporosis is a bone disease that weakens bones and making them susceptible to fractures even from minor falls or everyday activities. When you look at all the women that take treatment from a gynecologist, you'll realize that after their pregnancy is over, they feel that it's not necessary to go to the doctor. Their job is over, pregnancies are over, unless somebody has heavy periods or some other problem, they don't bother going. Pap smear is again unheard of. People don't even bother. And so also looking at the calcium levels and vitamin D levels. And as Nandita said, 90% of them have poor vitamin D levels. So it occurs when bone mineral density and bone mass decrease, leading to reduced bone strength. And mostly referred to as a silent disease because it doesn't usually cause symptoms until a fracture is seen. So women per se don't bother checking it, and unless as a routine things are checked in as some kind of a package, nobody even bothers checking whether their vitamin D, what their vitamin D levels are. And it's a chronic disease affecting 1 in 3 women and 1 in 5 men over the age of 50 years. And it's globally seen. Now, at this point of time at least, the gynecologists, if women come to them, we tell them that after the age of 45, taking calcium is a must. I don't think men bother going to any of the doctors to see what is happening as far as their checking is concerned. So the prevalence when you're talking about is fairly high. And why are women at more risk? That's because osteoporosis can occur at any age, although risk of developing the disease increases with age. And for most women, the disease begins to develop a year or two before menopause due to estrogen depletion. Estrogen depletion is something which is a gradual process, and women don't bother checking it, whether what is happening, unless there is a fracture or menopausal symptoms are evident in terms of maybe hot flashes or dryness of vagina or whatever the other situations are. So the bone loss and premature ovarian failure, cancer medication and long-term steroids make a lot of difference as far as the osteoporosis is concerned. Now you're all aware that the cancer has become a very highly prevalent situation as far as women is concerned, whether it is cervical cancer, breast cancer, ovarian cancer, and so on. And most of them are silent cancers and are detected very late. And these are the cancers when medication is required, you require chemotherapy and so on, and those affect the bone density as well. There are no typical symptoms in the early stage of bone loss, and once bones are weakened by osteoporosis, they include back pain due to broken or collapsed bones in the spine, loss of height over time, a stoop posture, or a bone that breaks more easier than expected. So the classical description of in a woman is called as the dowager's hump, when the osteoporosis causes bending of the woman, loss of height, and kyphosis, which is a chronic pain, and that's the time when people realize that there is something grossly wrong. The normal bone remodeling balances between osteoblast, which is formation, and osteoclast, which is resorption. The type 1 is the postmenopausal, where estrogen deficiency, which causes increased osteoclast activity, while type 2, which is a senile aging, which causes diminished osteoblast function and vitamin D deficiency. And the secondary causes, of course, are steroids, hyperthyroidism, and chronic inflammation. So when you look at the classification of osteoporosis, you look at two different parts, the primary and the secondary. The primary, which are happening in the postmenopausal, type 1 and type 2 in senile, while secondary, which is happening with drugs and corticosteroids. The factors which are non-modifiable, which are age greater than 50 are in a female, family history, race, body frame. And modifiable are the ones which are low calcium, vitamin D3, alcohol, smoking, sedentary lifestyles, eating disorders, and medications. If you look at the diagnosis with DEXA scan, risk factor, Nandita mentioned about the FRAX. So the risk level where you have the high, intermediate, and a low level with DEXA, and the division when it takes place where there is OP, which is yes or no, and if it is yes, the pharmacological treatment that needs to be done as against the lifestyles that need to be rectified. My perspective on osteoporosis is that it's a silent thief. Steals bone density without symptoms until it's too late. It's a preventable disease. Early intervention can significantly reduce risk. And a growing burden with aging population, osteoporosis is a global health crisis. When the average age of a woman was 60, you never saw so much of aggressive osteoporosis and bone fractures. But people are living up to 90 now, so that makes a major difference as far as the situation is. There's lack of awareness. Many people don't realize that they are at risk until a fracture occurs, and seen as a normal part of aging rather than a preventable condition, thinking that this is going to happen to everybody irrespective of what, and it's not preventable. So delayed diagnosis, screening, DEXA scans, etc. is often underutilized. The impact of osteoporosis, when you say the physical impact, the fractures, hips, spine, wrists, etc. lead to pain, disability, and loss of independence. Emotional impact, which is a fear of falling, reduced quality of life, and depression. And believe me, in menopausal women, a lot of the times you find that the depression leads them to a psychiatrist who has only two types of medicines, mood elevator and depression. So when that is happening, the osteoporosis and the depression, which is related to the estrogen lack, is not thought about. And you need to supplement them at that time with whatever form of, whether estrogen or subsequent equal substances or pharmaceutical agents, which can give a similar kind of effect, avoiding endometrial hyperplasia. So you have the soya extracts which are available, which can give you a similar kind of estrogen effect on the patient without causing endometrial hyperplasia. And the economic impact, which is the high healthcare costs for treatment and rehabilitation. So when you're talking about, I was just talking to one of the orthopedic person here, and he said that any woman coming in then requires surgery, and that surgery causes more problems and more, it just adds on and on and on, and it doesn't really look at the ultimate effect that is going to take place. So osteoporosis is a tremendous negative impact on the physical, emotional, and mental well-being of a post-menopausal woman. Now you need a lifestyle modification, and when you are looking at the pillars of current management, you have the calcium, vitamin D, weight-bearing and resistance training exercises, fall prevention, home safety and balance training. And unfortunately in our country, these home safety measures are completely lacking. So you have women who are aged falling in the bathroom because there is nothing to hold them when there is a fall, imminent fall, and there are no bars around to hold them to prevent that fall and fractures from happening. And the infographics or lifestyle recommendations which need to be done, and I am happy that the media as well as the Aditi's constant messages which go on Facebook and so on give a lot of information regarding all this happening. Now, what are the pharmacological therapies that we are looking at? I'm going to give you a nutshell of everything and not going to go into the details because I saw the program and literally everything is covered in that program, and I'm only the opening batsman to give the situation regarding the women at large. So it's biphosphatase, first line, reduce fracture risk by 50 to 70%. Then you have inhibitors, Rankle inhibitors of subcutaneous injections every 6 months. The anabolics, which are stimulate bone formation rather than the absorption taking place. And the SERMs, which are aloxafen for spine protection in the high-risk women. And the visual mechanism diagram with osteoclast versus osteoblast targeting. So, when you're talking about the newer advances shaping management, Nandita again mentioned some of the things that dual action monoclonal antibody inhibits sclerostin, increasing bone formation and diminishing the resorption that is taking place. You have faster anabolic effect than teriparatides, which are seen in the other varieties. The digital health tools, wearables for fall detection, apps for adherence, tracking, etc., and precision medicine, which is genetic testing for LRP5 and the pathway mutations. 50% of the discontinuation rate of oral biphosphonates is due to GI side effects. And that is something you must realize that you need to emphasize and explain to the patient. You have anabolics, which are expensive. You have atypical fractures, which are long-term biophosphatase use linked to rare femoral fractures. And the underdiagnosis, only 20% of high-risk patients receiving screening treatment. So prevention is the key. Promote calcium, vitamin D, and weight-bearing exercises, which you have to highlight to the patients. And social media can certainly do that much better than one-to-one direct contact which happens with the women. Encourage DEXA scans for at-risk population, especially the postmenopausal women and elderly. And education and awareness, public health campaigns to debunk myths and highlight the risks. There are stem cell therapy which has been recommended in future for a future direction, still in experimental stage, regenerating bone via the mesenchymal stem cells, nutraceuticals where collagen peptides, strontium supplements can be given, AI-driven predictions, machine learning to personalize fracture risk, and policy advocacy, the universal screening for the postmenopausal women that is necessary. So in conclusion, we have to have a successful outcome. We have to save bones, anabolics, rebuild them, access inequalities and gaps to adherence challenges, fear of long-term risk, and call to action to integrate innovations with preventive, prioritize patients with education. Education is the key to avoiding the problem which is existing. Thank you very much for patience.
Thank you, sir. Our next speaker for the next keynote is Dr. Dilip Tanna. He is a senior orthopedic surgeon specializing in trauma and joint replacement surgery with an experience over 50 years. Former professor at Nair Hospital and Medical College. Clinical practice at Jaslok Hospital, HN Reliance Foundation Hospital, Bhatia Hospital, Lotus Clinic, Mumbai. He was featured in Dr. D.D. Tanna's Story of a Legend, Trauma International, and he is recognized as a pioneer in orthopedic practice and education in India. Welcome, sir.
Okay, osteoporosis is only for practicing doctors. I wouldn't say orthopores because it applies to everyone. Marogoli to all the pundits' theory. I'm not bothered about it. I'm going to talk about the day-to-day practice treatment of osteoporosis. Who should handle osteoporosis? I spoke to two endocrinologist friends. How many cases they see in osteoporosis? Not more than 5-7 in a month, or maybe more, and all sent by orthopods. Then how do you give talks? Orthopods think we are expert and they call us. We read and speak. You and me, orthopods, see most daily few cases directly or indirectly. 8-10 cases on an average. In a busy practice we must be seeing daily. So we should be knowing it better, and we should be treating them more efficiently than physicians. Unfortunately, we miss our responsibility. World literature, only about 20% started treatment of porosis even in a fracture neck of femur at the age of 60, 70. My guess is only 5% must be treatment for even collisis fracture in elderly. Suggestion: almost all elderly neck, femur and distal areas need post-surgery treatment for osteoporosis to avoid second and a third fracture. When I said this in a meeting, one of the orthopods in purely fun commented, "Sir, that's the reason we do not treat them to get them again, the fracture, and back to us with a fresh fracture." Prevalence of osteoporosis fracture: 1 in 2 women over 70 will get an osteoporotic fracture. 1 in 5 over the age of 50 will get osteoporotic fracture. Who only females lose bones, why not men? Is a dilemma which I always had. World is always ruled by she-god. So man has all the diseases. Women has very few diseases. And let me tell, physiologically women are stronger than men, I have no doubt about it, except in a physical strength. But now women cricketers hitting sixes, we all have seen. When he god came to locum power, when she god was delivering a child. He god couldn't undo anything what she god had done it, so she gave osteoporosis to the women. That is how the osteoporosis came prevalent only in the women. By the time he god does more damage, she god, not trusting the husband, came back, and immediately after the childbirth has ruled the world all through. After that, they never had a second child, and that's the why there is only one God. And ever since then, our wives have always ruled us. Anyone disagrees? Sushrut, do you disagree? The common bones affected, we all know: vertebrae, hip bones, wrist bones. Now, if this is not treated, chances of a second fracture in vertebrae is more than 40% in a year. And you get multiple fractures, and you get osteoporosis, kyphosis, and all that thing comes in with osteoporosis. Height reducing due to porosis and vertebral fractures, we all know about it very well. Let me tell you about osteoporosis. Into the cells, the bone cells, these are the ones which are forming bone. These are the bone cells themselves are missing in osteoporosis. Normal matrix is there, but the bone cells are missing. So the bone formation doesn't occur. While this is the typical situations where bone cells are missing, the matrix is there. So only by calcium and vitamin D, osteoporosis will not improve. These osteoporosis cells go on only matrix, only calcium and vitamin D3 will not cure this. These are we all know the DEXA report. And unfortunately today, screening of the wrist and the heel, as fashion it has become in exhibitions and in meetings and everything, it is there, it is useless. I'll very emphatically mention about it. Screening is done with the belief that as the peripheral DEXA measurements gets higher, the chances of central DEXA measurements being low is less. Is not true. Mass screening test is not dependable. Do not fall into it. Suggestion: all neck, femurs and wrist fractures and vertebrae fractures need treatment for osteoporosis. Do DEXA for confirming and start treatment aggressively. Leave all those jargons of how L&O networks, rankles and osteoclast and all those damn things. I am not bothered about it. Essentially, no one can become rich by saving money. One can only become rich by making money. What can be done first to reduce the ill effects in the future? Build bones at 100% before menopause sets in, both men and women. Weight-bearing exercises is the only way to build bones. Walk, walk, walk. Swimming is not a good for a osteoporosis. It's a good exercise otherwise, but it's not a weight-bearing, so it's not a good exercise. Osteoporosis exercise, workout. That's the only way in which you can build up the bones before menopause or before aging. Before spine or hip fractures, it presents with vague pains all over in the back and thighs. This is the typical post-menopausal women get these all aches and pains. That's the time when you have to pick it up. I talk about the non-fracture female patient with vague pains above the age of 60 or below the age of 60. Rule out hypothyroid by TSH. Rule out vitamin D3 and B12 deficiency. Do a local study of phosphorus, calcium and magnesium. Even calcium, magnesium and phosphorus is supposed to reduce the osteoblast formation, so it is all three of them are important. And DEXA to see osteoporosis. I will also add PTH levels to see the parathyroid function, which will be raised in vitamin D3 deficiency. DEXA is also raised in osteomalacia. So first PTH blood investigation, if high, give calcium and vitamin D3, see PTH again, and if okay, repeat DEXA. Only in osteomalacia, DEXA will improve dramatically with treatment, never in porosis. Porosis, it only partially or marginally goes down or something, hardly ever it dramatically improves. Now after vitamin D and calcium, PTH is normal and DEXA is -2 or above, start calcium, elemental calcium, 1000 to 1200 a day, and vitamin D3, 60,000 units a week orally. Now here the catch is, Shalcal 500, oh sorry, I'm just giving the name. That 500 is not elemental calcium. If it is not elemental calcium, it is of no use at all. 1200 calcium carbonate is the only one which gives 500 calcium. So you have to see that there has to be elemental calcium 500, twice a day is the minimum dose. Majority of the people take once a day. And that is why the Femina and the female magazines start calcium as soon as you are 40, and they continue with one tablet a day. That is not enough. And if it is also not elemental 500, it is only 200 calcium they are taking, which is useless. So first is to prevention, which is exercise. Taking calcium regularly alone doesn't cure osteoporosis. Taking calcium regularly alone does not cure osteoporosis. Calcium is needed along with vitamin D. Femina and many female magazines and all drug companies made fortunes selling calcium to females all over the world. Prevention and management of osteoporosis, conscientious statement from Scientific Advisory Board of the Osteoporosis Society of Canada. Calcium supplementation cannot substitute for the hormone therapy in prevention of the postmenopausal bone loss fractures. Adequate amount of vitamin D and HRT today, which has become a confusing because some of those reports of cancer of the uterus and the breast has come up, but it has been considered to be a wrong reports, and HRT is considered to be today the best treatment for first 10 years after menopause. Still, hardly many people use it. Observation, large majority of the population has vitamin D3 deficiency. Vitamin D is necessary for calcium absorption, and only calcium intake will not improve the bone. So this is all we have taken. The available calcium has to be 1500 elemental calcium, 1000 to 1500, then only it is effective. Importance of calcium, vitamin D for osteoporosis, we all know it. What are the drugs used to treat osteoporosis? Now, HRT in postmenopausal women, I feel, is one of the most important treatment which you should continue, which is not being done regularly. Current phosphorus and magnesium and bisphosphonates. To me, bisphosphonates do not exist. It has a past. It doesn't exist today. Into the newer drugs which have come up, I would not think I have been using bisphosphonates of late. Teriparatide, yes. Denosumab, yes. Romosozumab, yes. Most are having vitamin D3 and oral vitamin D3. Some doctors advise injectable with the false impression that it acts faster, which is not true. Oral vitamin D3, 6,000 units once a week for 8 weeks or 6 weeks to be repeated arbitrarily every year is the treatment which I would presume is a standard treatment. HRT immediately, I have already talked about it. Calcium is needed with vitamin D3, so this is the one which all of us have to understand that you got to give calcium and vitamin D3. Now, calcium carbonate, we all know about it, is not enough unless it is 1250. I am repeating this again and again because majority of the people do not see this. 1000 milligram pill of a calcium carbonate will contain 400 milligram of calcium, less than half of your recommended dosage. So when you choose calcium tablet, 1250 milligram calcium carbonate is needed for a normal need. Now here, calcium deficient like rickets also happens in adults and osteoporosis. This is what is the typical difference between the two. What is the current practice in DEXA is -2 and then start bisphosphonates. So in one of those recent meetings on osteoporosis, one of the leader in osteoporosis said, please listen to this. Are we harming our patients by starting on alendronate, bisphosphonate first and then starting PTH? Bisphosphonate slows down the bone loss, which is normal in aging, that is like saving money. While PTH works by forming bone, that is making money. Listen, something different. How will you help by protecting empty walls by bisphosphonate first? There is nothing in the vault. What are you going to do about it? First, fill up the walls, earn money and then protect. So first put PTH, get your bone back, and now protect by avoiding bone loss by denosumab, not by bisphosphonates. So today the treatment is start teriparatide if there is an osteoporosis with fracture, 100%. If there is no fracture, then you may start with only denosumab. Bisphosphonates, I don't use it. So I come to a practical approach. How does the osteoporosis present? 39-year-old lady with this fracture, DEXA -3.5, surgeon operated and put on teriparatide, non-union. Any comments? Sorry? Teriparatide is not the? Why not? Sorry? No, sir. You can see there is the opposite side fracture. This is the stress fracture. This is a calcium fracture, osteomalacia. You do a PTH and give only calcium and that's all what is needed. This patient didn't need teriparatide, only vitamin D3 and calcium. Treatment of porosis, advanced science treatment, different doctors. Now this is very important. Different doctors are advanced at a different stage and hence the patient are advised different things by different specialists. Today a successful doctor, gynecologist or an endocrinologist or a bone specialist says you must take bisphosphonate. Patient believes. He is not advanced yet to the level in which it has to come. Or probably he is still not been convinced that the people who are talking about bisphosphonate is not needed is right. So some still vehemently advocate bisphosphonate while it is being replaced by denosumab. Denosumab withdrawal is reported with quick recurrence of porosis, so lifetime denosumab is a must. Don't stop denosumab. Atypical fractures is there enough, so disaster for a patient who gets it. It may be 3%, but 3% patients who get it is a disaster. And an alternate treatment of denosumab is available, so why the hell you have to use bisphosphonate? Alternate denosumab does equal job, so there is no preferred treatment. This is the preferred treatment over denosumab. If DEXA is minus 2.5, my approach, start teriparatide for 2 years. Teriparatide is superior to standard care in reducing the risk of the vertebral fractures. Combination of denosumab once 6 monthly with 20 milligram daily teriparatide is proved effective. That's the treatment of osteoporosis today. 10 years of denosumab has low complication rate, low incidence of fracture without plateau, as understood today. Bisphosphonate, the same thing was said when we started, you give bisphosphonate for life, and we have seen those those alendronate fractures which coming up. Bisphosphonates are now going out of favor for primary treatment. Denosumab has been considered to be safer. Practical suggestion, calcium and vitamin D supplementation for patients with a fracture immediately, yes. Teriparatide, yes. Teriparatide plus reloflexin, yes. Teriparatide with denosumab is the best combination today. Indian version of teriparatide and denosumab. I think this is most important for us as a cost-wise. Indian versions are known to be biosimilar, not approved anywhere outside India. Publication of different surgeons in India approves it. I can use original 40 or 90% of the time, but when I used Indian, I'm not very unhappy. That's all I can say. Use it if the cost is the issue. Avoid falls in the bathroom. We all know this very well. And the new drug, Evenity, which has already come. Romosozumab, once a month, is now currently preferred treatment. It doesn't need injection denosumab to start with. Till Evenity is given, start injection denosumab after finishing 1 year of Evenity. Once a month, 2 injections come, you have to give it both of them at the same day. This is the best possible treatment today. Only complication which is supposed to be those who are having a recent cardiac episode. They are the ones where it is contraindicated. Otherwise, Evenity is probably more easier and more convenient to give. My treatment today, PTH correct with vitamin D, calcium, till DEXA minus 2.3, 2 years of denosumab, 2 years of teriparatide with denosumab, and often I have started teriparatide after 4 or 5 years of holidays. There is a literature support for that. Because if you start treatment, the patient goes on. So 5 years or 6 years later, you can restart teriparatide. Recently, I start with injection Evenity if DEXA is minus 2 or less and presence of a fracture. If no fracture, DEXA minus 2, I give denosumab only. So now let us see what happened to some of the things when we continue this bisphosphonate for 7 or 10 years. This is the fractures which occurs, and 1 surgery, 2 surgery, 3 years, it just goes on and on and on. We enjoy. We enjoy doing these complicated surgeries, but the patient suffers all the time. Now, what is the position of bisphosphonate? Zoledronic acid compliance is good, but atypical fractures, very low priority as denosumab is taken over. Atypical fracture is a treacherous complication which is at present not reported by denosumab. Same was with bisphosphonate when it came. So with denosumab, after 5 years or 7 years, what is going to happen, we don't know. So practical suggestion, calcium, vitamin D. As I said, you start immediately if you have a fracture. Teriparatide with denosumab is preferred combination today. My guess is Evenity will be preferred over teriparatide due to its monthly dose. Can you put on the sound, please, here, computer? Sound is not there? Be focused on the treatment. Do not lose focus. Just do not wander around. Thank you very much.
Thank you, Dr. Tanna, for that very lucid talk. Our next speaker for the next keynote is Dr. Vijay Neglur. He is consultant physician and endocrinologist, director at Dr. Neglur's Diabetes Specialty Center, Thane. He is also consulting diabetologist at Jupiter Hospital, Thane. Current positions: he is a fellow of Indian College of Physicians, president of NADR.
Thank you, Aditi.
Thank you.
I think get short that introduction.
Yes,
We
welcome,
can
sir.
focus on the discussion. Thank you very much, Dr. Aditi, Dr. Shushruth, for inviting me to speak on a very important subject of osteoporosis. What do we think of osteoporosis management? And since I deal with diabetes, I thought I'll speak on osteoporosis and diabetes. If we go back in the history, in 1800, it was John Hunter who first time diagnosed osteoporosis. And then eventually, after 30 years later, his one colleague from France, whose name was Jean Lesbian, who was the one who identified on the specimens holes in the bone. And he said there are holes in the bones in normal people also, and in people who are elderly have larger holes. And therefore he says porous, and that's why the osteoporosis name came into picture. It's interesting to see there are many inventions done by surgeons in the field of medicine, not forgetting Banting and Best, who was also a surgeon who discovered insulin. So let's see about diabetes and osteoporosis. So Elliot Jocelyn was again a father of diabetology, and he was the one who said that management of glucose is very important. And if you don't control your sugar well, you get the problems like fracture as a part of microvascular manifestation. When you get microvascular manifestation, we talk of retinopathy, neuropathy, and nephropathy, but we don't talk of fractures. If you look at the bone has the capillary network, which has a size of 5 micron. And therefore, involvement of these vessels in the bone do contribute to fracture. And therefore, I personally believe that involvement of the skeleton in patients of diabetes is a part of the microvascular complication. We all know about the bone health and many contributors for that. 60 to 80% is the genetic contribution. We have the nutrition, which all of us have spoken earlier. Hormones, we know the various hormones like PTH, the vitamin D, estrogen, and testosterone. I think all of you know that ultimately the peak bone mass is very important, which tells you the health of the patient's bone. I think this has already been discussed. I'll skip this slide. So what happens in patients of diabetes? We have a hyperglycemia, does affect the bone turnover. I'll come back to it a little later. The advanced glycated end products hang on to the collagen, which is type 1 collagen that we see in the bone, and that accumulation causes the impaired bone material properties. And the duration of diabetes goes on and on. This process continues. And we also get the complications of diabetes like neuropathy and nephropathy and retinopathy. And that, again, results into hypoglycemia and also falls, which are very frequently. And the microarchitecture is also there. And that ultimately results into fractures in patients with diabetes. We know that the falls are very common in diabetic patients, predominantly because of neuropathy. But there are other factors as well, like poor vision, the osteoarthritis, the cardiovascular factors like arrhythmias, the cardiovascular accidents, hypoglycemia, and also low vitamin D. Now, talking about the disease of diabetes and the fragility is based on the excess amount of the advanced glycated end product, which affect the collagen cross-linking, and decreased alkaline phosphatase also brings about decreased mineralization of the osteoid. And binding of RAGE to the age, there are receptors for the age, and this combination brings in a lot of pro-inflammatory milieu, which ultimately results into increased bone fragility. So it's insulin resistance, which is also important for the bone health, and that's why the controlling of diabetes is very essential, especially in patients who have diabetes with fractures. Now, this is a study from Taiwan, which looked at about 20,000 patients over a period of 10 years. And what did they see? As you see changes in the A1C, you increase fractures. You can see here, those patients who had A1C less than 6 had less amount of fractures, but those who had A1C higher than 10 had more amount of fractures, suggesting that the hyperglycemia does play an important role in the management of patients with diabetes, especially with the fractures. There are two important differences between type 1 and type 2. And you see that in type 1, the incidence of fractures are pretty higher compared to type 2. In type 2, there is, of course, the fractures, but it is much lesser. Why am I worried about the diabetic patients and fractures? Because there's a delayed healing, there's a higher risk of complications, there's higher mortality in these patients, and reduced independence existence because of the fractures in these patients. And this is the meta-analysis looking at 7 studies, which says that the incidence of fractures is 5-fold higher in patients of type 1 diabetes compared to general population. And this again says it's because of deficiency of IGF-1, because of insulin deficiency, this IGF-1 is less, and therefore these patients have poor bone quality, and therefore they get fractures very easily in type 1 diabetes. Interesting though, in patients of type 2 diabetes, the BMD is higher. It's higher by about 5% at the radius, 5% at calcaneus, and 3% at femoral neck. And this is a higher in BMD in patients of diabetes. And why do you get higher BMD in patients of diabetes? Is because as these patients are a little obese side, and also the insulin resistant, they have high levels of IGF-1. And that's why these patients tend to have high BMD, yet they get fractures, despite the fact they have high BMD. And what's important here is the hyperglycemia, which affect the osteoblast and osteoclast, which brings about decreased bone formation, bone resorption. But the sclerostin, which is affected again by the hyperglycemia, decreases the bone turnover, there's increased mineralization, and therefore the bone mineral density is higher in patients of diabetes. That has to be kept in mind. So when you estimate BMD in patients of diabetes, do not go with the standard factors that this patient's BMD is normal, therefore is unlikely to have fractures. That should be kept in mind. And I told you the reason why they get this is because the collagen getting affected by the glycemia, and therefore this glycemia impairs the quantity of the collagen. And we all know that the bone has type 1 collagen, which because of hyperglycemia has the accumulation of the advanced glycated end product at various sites in the collagen, and that of course impairs the bone material and its strength. We all know about the DEXA scan, we all talk about it, I'll skip that. But the point that I was trying to highlight is BMD is predictive fracture risk at the higher level in patients with diabetes. If we look at people with diabetes, they have a high BMD. If you look at the normal population, and if you see the T-score, it's -2, which has a risk of fractures about, say, 8% in general population. But if you look at diabetic patients, you have 15% risk despite the fact that they have low BMD. And therefore, when you have BMDs in patients with diabetes of -2, please add 0.5 to that, make it 2.5 to qualify this as the BMD for diabetic patients because they have normally higher BMD. The TBS score is another important software that we have in the BMD machine, which tells you about the trabecular score, which is also good, which is a software which is now developed, not available routinely. It has no units though, because there are people who have high BMD, but you just can identify these patients at risk for fracture by looking at the TBS score. If somebody has the score of less than 1.200, these patients have a higher risk of developing bone fractures, despite the fact that they have normal or high BMD. I think all of us know about this FRAX score, everybody talks about it. But when you talk of diabetic patients, you have to do 3 corrections. One of them, either you increase the age by 10 years, or you tick the rheumatoid arthritis in that column when you look at it, or reduce the T-score by 0.5. If you get to all this, then your FRAX score is matched to the patients of diabetes, which is corrected when you use this kind of FRAX score. And therefore, anybody who has the fracture risk of more than 20% has 10-year probability of the high fracture risk, and the fracture risk of more than 3%. The patients of diabetes, in nutshell, have these 3 problems. They have a disease which comes at much younger age. They have central obesity, and they have high inflammatory markers. All of them adversely affect the peak bone mass and eventually results in diabetic bone disease. And to contribute to this, we have the high prevalence of vitamin D deficiency, and we have the early menopause in patients of diabetes contributes excessively to the bone disease in these patients. And therefore, this is the thing everybody has spoken that, but I want to only point one thing, important points. Review the medication the patient is taking. And therefore, if the patient is taking metformin, DPP-4, and GLP receptor agonist, they are quite safe in patients of diabetes for the bone disease. Sulfonylurea and insulin and canagliflozin are known to induce fractures, especially in insulin because of the hypoglycemia, they get fall. And pioglitazone should be avoided in the postmenopausal women because of the increased risk of fractures in this population. When you treat patients of osteoporosis, these are two approaches that we have. We have either they block the bone breakdown or promote the bone health formation. We have all those drugs, and the previous speaker has spoken in great detail about it. I'm only talking in relation to diabetes. So therefore, the current clinical tools in the treatment of osteoporosis is very important. Then you diagnose when the patient gets a fracture. Then you identify that he has the fragility fracture or he has fracture because of osteoporosis. Then you have all those drugs, bisphosphonate, denosumab, and so on and so forth. Can you have any drug to prevent this? A very good work was done looking at beta blockers to treat or prevent the osteoporosis. And this is non-selective beta blockers, and at a lower dose, between 20 to 40 milligrams of propranolol was used in this population, and they showed convincingly, both in the human population, in the Women Health Initiative study, and also in the animal model, that there were decreased levels of bone markers in patients who received beta blockers, and also the BMD estimation was also proved to point to say that the beta blockers do have an impact on reducing the osteoporosis. I think a lot of cardiologists here, and these cardiologists will be using beta blockers quite frequently, but they use all selective beta blockers. Now we have been using all selective, non-selective beta blockers are used only by neurologists to treat migraine. So therefore, it is important to reconsider the possibility of using these beta blockers to prevent osteoporosis. We all talk of prevention. I think all these drugs are discussed in details. I will not go into much in detail. But what in terms of diabetic patients, there is limited data on the efficacy of anti-resorptive and anabolic therapies in patients of osteoporosis in the setting of type 2 diabetes. All are based on the post hoc and the subgroup analysis of randomized controlled trial. And there is no head-to-head trial to compare this in patients with or without diabetes. These are the hitherto available data that we have. The data is very limited, and whatever important things I'll talk about it. Bisphosphonates in type 2 diabetes. There are two studies which looked at, one is FIT study and Horizon study, which estimated that the risk of non-vertebral fracture reduced by, relative risk reduced by 0.52, that's 48% reduction. And the vertebral fracture was reduced by 66%. So that's how you get these benefits in patients when you use bisphosphonate in type 2 diabetes. Denosumab, the Freedom trial, which has a small population of diabetic population, 266 on denosumab and 242 on the placebo therapy. It interestingly showed reduction of vertebral fractures, but it showed increased in non-vertebral fractures. So we don't know whether denosumab is quite okay for patients of diabetes. That's a problem. The denosumab also reduced the fasting plasma glucose in patients of diabetes. Teriparatide, the evidence by the DANCE trial, which is the direct analysis of non-vertebral fractures in the community experience, it showed a similar results at the end of 24 months between diabetic and non-diabetic population, and number of people studied were 3,751. To conclude the talk which I finished, I think I have a little time left because we are running behind schedule. See, diabetes leads to increased fracture risk, type 1 more than type 2. Fractures in diabetes portends a poor prognosis. Bone disease in diabetes must be treated. FRAX scores need to be adjusted in patients with diabetes. Both anti-resorptive and anabolic therapies are effective in patients with diabetes. With that, I conclude my word. Thank you very much.
Thank you, sir, for that talk. I now I'd now like to request Dr. Nandita Palshetkar, Dr. C.N. Purandre, Dr. Dilip Tanna, Dr. Vijay Neglur, and Dr. Sushrut Babulkar for the lamp lighting and unveiling of the logo. Requesting to call Dr. P.C. Mohapatra as well. The cameraman is requesting to look at Can we unveil the logo, please? This is the official unveiling of the logo. I'd now like to request Dr. Shailesh Pitle to come on the dais to introduce the founding council members.
Good evening, all. It's a great pleasure to be here for this evening, the inception of Osteoporosis Society of India at this iconic Taj Palace at Mumbai. And as has been mentioned by the stalwarts earlier, I think this is just the beginning, and it's going to be a long way for all of us to work together for this society and take care of this significant medical problem which is hitting our patients and the society at large. So we have, excuse me.
Pragya, can we? Yeah.
We need the CVs. CVs. Yeah.
The founding president of our society is going to be none other than Dr. Shushrut Babulkar, and he is going to lead the way for all of us with this society. And being Shushrut's batchmate, I know him since college days. Shushrut has been a trendsetter since beginning. Shushrut has done his MS Orthopedics from Nagpur, and after that has achieved great heights. He is presently the director of Shushrut Institute of Medical Sciences at Nagpur. He has done specialization in trauma, fracture, and he has a lot of professional achievements. More than 28 years of advanced orthopedic surgery. He has been the director of 2 leading medical and research institutes, has been a national faculty and trainer in orthopedic training care, and has led and participated in multiple clinical trials. He has been a member and a founding member of many national and international bodies. And to his credit, he has umpteen number of publications in peer-reviewed journals, a lot of books that he has published, and he's a thorough academician. And one great feather which is added to his cap just recently yesterday is Shushrut has been nominated on the United Nations Ethics Committee to represent India. This communication he got just yesterday. Heartiest congratulations, Shushrut. And we are privileged to have Shushrut as our president, founding president of Osteoporosis Society of India. May I request the council, so is the installation going to now? The other team members who will be joining Shushrut are other stalwarts, Dr. Nandita Palshetkar, who is a founder and medical director of Bloom IVF. She has been already introduced. She is a known faculty, a renowned figure in the field of gynecology, and she'll be helping us looking at the women's health in osteoporosis. Dr. Seema Dande, she is not here today with us, but because of some personal commitments, she is going to be the Joint Secretary of Osteoporosis Society of India. Seema Dande is a gynecologist at Nagpur, at Dande Hospital, and she has been practicing at Nagpur for around 2 decades now. Dr. Chetan Pradhan is the incoming Vice President, and Dr. Pradhan is a known figure in the field of orthopedics, has done a lot of work in trauma since 1996, AO Trauma Fellowships, many other international trauma fellowships. He is on the AO Trauma Council member, West Zone, and he has many index publications, his area of interest being primary, complex and revision trauma. The other vice presidents, we have two more vice presidents, Dr. Sanjay Kalra, who is an endocrinologist at Karnal. He is not here with us today. Sanjay has been a very active member of the Endocrine Society of India. He is the past president of Endocrine Society of India. He has done a lot of work in endocrinology, published a lot of books, and Sanjay will be the vice president of Osteoporosis Society. And then the third vice president is Dr. Charmila Ayu. She has been the vice president of FOXY, vice president of Trichy Obs Gynae Society, secretary of the society there, and she's been a member of many important bodies, governing council member, and has been a part of many active gynae forums.
I would like to introduce Dr. Shailesh Bitale. He will be taking over as treasurer of the Osteoporosis Society of India. He is consultant endocrinologist at Nagpur, director at Dew Medicare and Trinity Hospital, honorary associate professor at IGGMC, Nagpur, president of Diabetes Association of India, Nagpur branch, associate editor of the Journal of Clinical and Translational Endocrinology Case Reports. He has various articles in international journals to his credit and various chapters, and 4 international awards for original research, award of the AACE in 2000 and 2009, Best Research Award, Rush University, and his area of interest is insulin resistance and obesity and thyroid disorders in pregnancy. Welcome, sir. And the joint treasurer who will be taking over is Dr. Ashutosh Apte. He's also not with us at the moment. He's an orthopedic surgeon. I would like to now invite Dr. Tanna to kindly give the memo to Dr. Sushruth for the installation as president.
Tanna sir, तुम्ही इथेच थांबा ना. So may I invite now my backbone, my Secretary General, Dr. Nandita Pashetkar to come. So stay here near me so I can be faster. May I invite Dr. Charmila Ayavu to please come. She is the Vice President 1. Chetan Pradhan, Vice President 2. Shailesh Bitale, the Treasurer. And Mr. Subramaniam, Subbu as we fondly call him, as our knowledge partner, Science Integra.
Requesting Dr. Sushruth to please also felicitate the keynote speakers. Dr. Nandita Palshetkar. Dr. C.N. Prandre, I think, has just left. Dr. D.D. Tanna. Dr. Vijay Neglur. Requesting Subbu to say a few words.
I won't take much of your time. My name is Subramanian. Generally, people refer to me as Subbu. A lot of times, people end up asking, do you report into Subramanian in Science Integra? And I say yes. So, just to give you an insight that Subbu and Subramanian, both are the same people in front of you. That's who I am. I represent a group called Science Integra, and Science Integra is basically a healthcare communications company. We are pioneers in healthcare communications. Most of the publications that you would have seen in the country, we used to contribute to almost 40% of the content of these publishing houses worldwide. So that's our strength. We believe in supporting medical associations with scientific content, CMEs, conferences, and everything that is under the spectrum of science. I would surely take this platform to acknowledge two people in my life who have made a huge difference and who have given an opportunity without blinking an eyelid, and that's Dr. Nandita and Dr. Sushruth. They have given the opportunity to work along, showcase, whatever possible strengths and consolidate on their vision, their ideologies, and what they are wanting to do for the community, larger interest of the community. At the same time, I would like to So there is a quick view into who we are. I just spoke about it. This is what we do. We contribute to the professional development of healthcare practitioners, and we help in disseminating disease management information through data research and, of course, through publishing. And some of our work that we do, we have a peer-reviewed journal which we have launched, which is the Journal of Trauma. This is an online journal. It is already supposed to be indexed. This is under the aegis of the Trauma Society of India. We also are releasing the mouthpiece for the Osteoporosis Society of India today, and that is going to be Osteoporosis 360. May I request Dr. Sushruth Babulkar sir and Nandita madam to please come on stage and do the unveiling of the newsletter, which is the official mouthpiece of the Osteoporosis Society of India. May I request Dr. P.C. Malhotra, Dr. P.C. Mahapatra sir, Dr. D.D. Tanna sir, and Saraya madam, please join us for the unveiling. Sharmila madam, yes. So that's the official newsletter. Yeah, thank you so much, doctors. Go ahead. And that's our future plans. We promise that we will support in the continuing medical education and also supporting the Osteoporosis Society of India in helping launch and create more footfalls across every corner of the country through registering, forming multiple associations, state level, city level. So that's the next step, and Dr. Sushrut will talk more about it at depth. So thank you so much, ladies and gentlemen. Please enjoy the evening.
Requesting Dr. Sushrut Babulkar to kindly give his presidential address.
Can I get a mic here as well, please? A hand mic. So I have a story to tell. This was way back in 2002, and I was on medical advisory board of Eli Lilly that time, Eli Lilly Europe. And hi sir. And there was a very famous Bollywood actor that time who had sustained vertebral fracture. He was being treated by one of the endocrinologists sitting here. That time, Frailty was only allowed 6 months of therapy. And in 6 months, he was showing rapid improvement. And then more than 6 months was not allowed. And he approached Eli Lilly company, and Eli Lilly said, this is a doctor who is in Nagpur. What Nagpur? I don't know Nagpur. So no, you go talk to him. He may approve another 6 months of therapy, because in US already 1.5 years was approved that time. Now it's 3 years. But those days 1.5 years was approved in US. So he said, no, I cannot talk to anyone. I have got my 25th year celebration of my movie which I had made and which was a big hit, and I must go for that function. You make me walk. So Eli Lilly said, okay, we will make a phone call. You talk to this doctor. So phone call was made to me, and I said, okay, you are my favorite actor as well. We have grown watching your movies, and we know that you are so patriotic while making the movies also. So okay, as a special permission, we give you another 6 months of teriparatide, Frailty. The actor unfortunately is not here today, but he had promised me 3 months back when me and Nandita started talking about forming this kind of association, and he said, I will come to this function. Unfortunately, we lost him. The movie was Kranti. The actor was Manoj Kumar, and Manoj was giving him the treatment. You are not. So these are the fractures which come to, and Tana sir, Chetan, Ram will agree, Ashish will agree with me. Thus, with increasing complexity of osteoporosis, we as orthopedic surgeons, we need to do more work on these osteoporotic fractures. And when we start thinking of complicated fractures which are absolutely amenable to routine fracture treatment, we are faced with a havoc situation when we have to put in not only one device or a plate or a nail, but a combination of nails and plates, and it takes a lot of our time. Still, we are confused what should we do for this complex, complicated osteoporotic fractures, because we think, Tana sir told that, okay, we think that we get many patients, but then once we start and put them on some osteoporotic treatment, they will go to every one of us sitting here. They will go to endocrinologists, ladies will go to gynecologists, and if there is any difference of opinion, the patient gets confused. Now this is the same principle of why and how ATLS was developed by American College of Surgeons. So when I went to UK, we were first told to undergo this training of advanced trauma life support. Why? Because when a typically patient comes of poly to a hospital. A house officer will give him normal saline. Then the registrar comes, he says, no, he has lost a lot of blood, give him blood. Then the lecturer comes, he says, no, don't give him whole blood, give him plasma concentrate. Ultimately, patient doesn't receive anything. So American College of Surgeons decided ATLS, only ringer lactate will be available at casualty, and this is what is to be given. So guidelines need to be across the pathies who are treating the patient right from the age of premenopausal to postmenopausal to, of course, diabetes, and to, of course, patients getting fragility fractures. So we need to be all on same platform, at least for the patient's benefit. So that was the whole idea why we thought that we need to avoid such situations wherein our implants are walking away and we are faced with a crisis that how to save these hips, how to fix these fractures, at least have some good bone to fix our implants onto. So the vision we all should have, we must envision a world where osteoporosis probably will be a rare condition and individuals will enjoy optimum bone health. So that's a vision. We have to have some vision somewhere. Of course, when we go back to our practice tomorrow morning, we all will be orthopods, you will be endocrines, and you will be gynecologists. But at least somewhere in the mind, we should have some vision that together we must aim to achieve significant reduction in osteoporosis, related fractures, and improve the quality of life. Because we are going to be there as well. We all are going to reach there. Don't forget this fact. And of course, me and Tanasa, we were talking about his particular injury, and suddenly even the topmost orthopedic surgeon considers that he is an Iron Man and he will be immune to osteoporosis, which one is not. So we should collectively dedicate ourselves to raising awareness about osteoporosis related conditions. We should focus on providing education, resources, and support to individuals at risk. And our goal, of course, is to promote bone health. What is our role as a society? What is our role as colleagues who are like-minded, who are going to strive for development of education of the society? Is collaboration of all like-minded individuals sitting here to come together who are currently actively involved in treating various stages of osteoporosis to formulate one set of guidelines for prevention treatment. Of course, orthopedic surgeons, as orthopedic surgeon, we have just come out with our Indian Journal of Orthopedics dedicated issue on osteoporosis last month. I know as BMR has their own set of guidelines. I also know postmenopausal guidelines exist in gynecology. But the problem is, I do not respect what ISBMR tells me. Gynecologists will not respect what an orthopedic surgeon talks. So if we all organization come together, sit across the table, break our head, create one guideline which is palatable, acceptable, and then spread by individual organizations. Probably our patients at large will get benefited. Probably we will not have any cross reactions amongst us. So we must empower our colleagues at every level with this current knowledge which is acceptable, and of course we'll have some safety protocols. So what will and what should be our key initiatives is to educate our own colleagues at all levels and give them weapons like FRAX score, guidelines, etc. Of course, FRAX score is not typical FRAX score now, it is India specific FRAX score, but the downside of India specific FRAX score also, Shailesh, is we need BMD. And BMD is not so economically, no. So now, educate us on all those things which are possible sitting on OPD basis. So you do that. And once it is possible to screen all those patients who are supposed to be approaching for osteoporosis or related complications, which will also be done by public awareness campaigns. Of course, we should have also funding for cutting-edge research on prevention of falls, sarcopenia and osteoporosis. We must have workshops, seminars and conferences, Nandita. And that brings me to another point, that why not at least kickstart with having some national level meeting very soon. That will at least set the ball rolling. That will at least gain some momentum. And I was talking to Shailesh also that 4th, 5th, 6th of July, we already have Nagpur trauma course in Nagpur. So I offer 6th of July as our first national conference in Nagpur. Have one dedicated day and we will plan it and at least gain some momentum to this activity. So that's what I think. So the mission statement should be, our mission is to bring together all the branches of medicine to create a unified guideline for treating all patients. We should aim to prevent osteoporosis and improve the quality of life through collaborative education, advocacy, and comprehensive medical and community support. And I must here thank Subbu and his team, Science Integra, and our event partner, WAMA team, to be our backbone to support what we envision to achieve in near future years to come. Thank you very much for your attention. Aditi, over to you.
Pragya, can you help me with the CVs? It's already on. Yeah. I'll just run through the other members of the council. Yeah, the social media committee, Dr. Rohan Palshetkar, Dr. Ritu Hinduja, and myself, Dr. Aditi Tandon. The website committee, Dr. Madhur Verma and Professor Nitin Kapoor. Executive members, academic chapters planning, Dr. Jayam Kannan, Dr. Preeti Kumar. Advisors, Dr. G.S. Kulkarni and Dr. S.S. Amarnath. And annual conference planning and CME planning, Dr. Ameya Purandare, Dr. Mangesh Tivaskar, Dr. Lakshmi Nagendra, Dr. Saurabh Sharma, and Dr. Rakhi Singh. For the next talk, I would like to invite, and it's my extreme privilege to invite Dr. P.C. Mohapatra. He is former head of Department of OBGYN, SCB Medical College, Cuttack, mentored numerous postgraduate students and contributed to academic excellence in women's health. He's director, Prachi Institute for Mother and Child Care, a leading center which provides advanced obstetric and gynecological care in Cuttack. He is past president of FOXY, speaker and participant in educational forums such as the e-Gurukul series addressing key topics like preterm labor and maternal health, contributor to public awareness and women's health education via platforms like the Times of India. Welcome, sir. He will be speaking on osteoporosis and fragility in elderly women, role of gynecologist in prevention.
Over the last 45 years, the audience was gynecologist. Very few occasions I find a conglomeration of the various disciplines of medical fraternity. Here, physicians, surgeons, orthopedic surgeons, endocrinologists, and the different faculties of medicine. See, the physicians, surgeons, and gynecologists, the primary faculties, disciplines, all have the same aim of alleviating disease and suffering of humanity. But the temperament is different. the surgeons, orthopedic surgeons, they feel that we have got two hands. We can win the world by our two hands. The physicians say that we have two brains. And with the two brains we can think, and by thinking we can win the world. But we gynecologists say that the whole universe rests with our two fingers for that. And I'm very happy that this evening we had a conglomeration of various disciplines aiming at solving a problem of osteoporosis, and that's why they're born in a new society, Osteoporosis Society of India. Well, there is no dearth of society in India or in the world. In our own faculty, we have got different subspecialty and different societies. But there is a need. This is something which is a collaboration of other disciplines for a common objective of a particular very prevalent entity, both men and women. And therefore, OSI, the Osteoporosis Society of India, was born. I congratulate all the council members, the president and the secretary, and everybody for the purpose of bringing us together for that. And I'm really quote from Dr. Tanna that how powerful is she God and how powerful is F God. FG means Foxy combined with Aussie. Only then you can grow and all that for that. And therefore, I thought that all gynecologists present over here are fortunate here to be combined with this particular entity for that. Well, the collaborations is not new. We are the specialty, the gynecologists are the mothers. We are the mothers of almost many societies born in this country and globally also. Because we are a special healthcare provider who deals with the creation to cremation. I think that's why we have got a collaboration earlier with the Aishoparp Society, with the Pediatrician Indian Society of Perinatology and Epidemiology, with the fetal medicine, with the radiologist, with the IFMBB, with the radiologist, with that, cosmetic gynecology with the dermatology, and urogynecologists with the urosurgeons. And now we are fortunate that we are combining with a hard core, I think orthopedician, hard combining with a soft entity, and in between the interim part of the endocrinologist for that. I congratulate this effort for combining this for that. And ultimately, I wish that this society will grow for the purpose of well-being of the mother with the men and women combiningly, so that our achievement will be there for that. I think I will propose one thing, that the society is a combination of everything for that. Find out who are the wives are the gynecologists, husbands are the surgeons or orthopedic surgeons. I think find out them and become a member, so that I think this society will grow a long way for that and way forward for that. I bring greetings from the place of Lord Jagannath. Well, I have been given a different topic. I will not speak on osteoporosis. Frailty of women. I have given a talk on frailty of women. And this is the life cycle of a woman from the infant to the toddler, to the adolescent, to the full-blown women and a perimenopausal age group, and ultimately from beauty to frailty. And my talk is on frailty and osteoporosis today for that. Thank you very much for inviting me for that. So frailty in elderly women and osteoporosis, and what is the gynecologist viewpoint, has been the talk given to me, and I will present within a couple of minutes for that. Well, the prevalence approximately 10% of the people aged more than 65 live in frailty. 25% to 50% more than 85 years of age. No more frailty is a literary term. It is also a technical term for that, and the definitions have been there, what is called a frail women. Recent systematic review and meta-analysis across 62 countries worldwide found the prevalence of frailty higher among women, 15%, than men, 11%. But there is a sex frailty paradox, meaning thereby that the mortality rate is lower in women than in men. And the cause is obvious for that, starting from the genetic issues to the different hormonal imbalance for that. So frailty in elderly women is a state of increased vulnerability to adverse health outcomes, reduced muscle strength, fatigue, slow movement leading to falls and complications thereafter that, associated with altered hormonal changes as gynecologists perceive with this condition for that, and reduced anabolic response to protein synthesis and chronic low-grade inflammation for that, And these are symptoms that could indicate you have frailty, which include a spectrum of symptoms like fatigue, losing weight, balance and stability issues, leaking pee and poop, social isolation, depression, and so on and so on. So the symptoms of frailty are frequently feeling fatigued or exhausted, muscle weakness or reduction in strength, moving slowly or having other trouble moving around due to decreased strength and flexibility, having trouble with balance and stability, leaking pee or poop, urinary or bowel incontinence, and after all, social isolation for that. But the content is mainly the www, the weakness, the wasting, and working slow for that. And these are some of the factors which govern around this particular entity. It's not age related. Certainly age related is a frailty, but it starts not from all cases. So genetic factors, epigenetic mechanisms, environmental factors, cumulative molecular and cellular damage, giving rise to reduced physiological reserve in various systems of the body, and then physical activity, nutritional factors adversely affect, combination gives rise to what is a condition of frailty for that. And fails, falls, delirium, fluctuating disability, that needs an increased care needs, admission to hospital, admission to long-term care for that. Menopause. My gynecologist viewpoint, I will say that we have all dealing with osteoporosis have been discussed in many seminars and workshops in our forum. In the Indian Menopause Society, we have a couple of discussions with that. And rightly, what the president now tells that there should be a uniformity between the different faculties treating, and one voice will be there, not three voices for that. Menopause is not an end of life, but a change of life. It says, we always say don't pause for menopause. It is a transition for second adulthood. And ovaries are a wonder organ. Ovaries, after long years of dedicated service, has not an ability to retire gracefully. Instead, this wonder organ affects irritation over various systems of the body and organs, manifesting all these symptoms, including the osteoporosis for that. But studies show that there are differences between Indian versus westernized women. In menopause, urogenital atrophy and vasomotor symptoms are predominant in Indian women, not osteoporosis. But osteoporosis and mental health problem are predominant in Western women for that. That's a great difference between the Western women and Indian women for that. So frailty and osteoporosis, what is an Indian perspective? 80% of women, the peak incidence of osteoporosis in India occurs 10 to 12 years, 20 years earlier than in Western countries for that. And therefore, more attention has to be given on prevention rather than the treatment for that. The frailty and sex-specific pathological characteristics in older starts from the osteopenia, osteoporosis, sarcopenia, which is all known as osteosarcopenia for that, and therefore gives rise to a fracture, incidence of fracture and recurrent fractures for that. The missed diagnosis is there. Starting frailty syndrome often goes undiagnosed. The study revealed a significant correlation between osteoporosis and frailty syndrome with predictive accuracy of exceeding 75%. And the area of disability and mortality revolves around many factors like increased healthcare costs, polypharmacy, fragility fractures, delirium, weight loss, falls, recurrent hospital admission, and malnutrition and institutionalization for that. So frailty and women hormones in both the frailty syndrome and osteoporosis, hormones testosterone, estrogen, growth hormone, IGF-1, vitamin D and cytokines fluctuate similarly. Sarcopenic obesity, the coexistence of excessive adiposity and low muscle mass function is one of the leading causes of frailty. And importantly, osteoprotegerine, a marker of robust osteoclast activity, was significantly enhanced in patients with both osteoporosis and frailty syndrome based on Fritz criteria. And there are a number of literatures available, starting from reproductive factors and their association with physical and comprehensive frailty in middle-aged and older women, and there is a large-scale population-based study. And there was a J-shaped relationship between the age of menarche, reproductive period, and frailty. Age at menarche less than 30 years and more than 60 years, 16 years, reproductive period less than 35 years or more than 40 years were all associated with increased odds of frailty. That there was a negative linear relationship between menopausal age. Surgical menopause was associated with 30% higher odds of physical frailty for that, and that is also a very significant factor. It is a surgical menopause with that. This is again a literature journal of the American Genetic Society gives one of the hormones that diminishes during menopause is estrogen, which plays a crucial role in maintaining bone and muscle mass for the health. And meta-analysis conducted claimed that the risk of Frailty syndrome in women is reduced by 2% each year that a woman experiences menopause later in life. And what are the interventions? The interventions should be by everybody for that, and therefore start nutritional interventions. One of the important part is the nutritional interventions for prevention of this particular syndrome. Exercise intervention, Dr. Tana has already pointed out how balancing the exercise is important, and walking is the best form of exercise, not the aerobics for that at this particular age for that. Pharmacological intervention. Many controversies surround about this particular entity, pharmacological intervention. Gone are the days when HRT was very popular, and we have seen the pre-WHI era and post-WHI era for that. HRT, ERT or progesterone aiding giving rise to increased bone strength for that, we have seen for that. So pharmacological intervention we divide into hormonal component is one aspect, and the other controversial thing which has already been spoken about, and all these things have been given importance to the terapeptide or the decaxudam and all these second generation of this generation, and discarding the biphosphonates. There was a time when biphosphonates was the first promoted by that in gynecology for that. I remember how science changes and all that. I remember in 1937, J.J. Thomson get Nobel Prize by showing that electrons are waves. And his worthy son after 30 years, J.J. Thomson again got a Nobel Prize by proving that electrons are particles, not the waves for that. But which is correct? Whether the particles are correct or the waves are correct. But the only good thing is, correct thing is that both the father and son are the Nobel laureate for that. So this is the thing which goes on science for that. And science also, we should compromise that. I always believe that we believe in the literatures. We believe that the publications for that also. My personal view is that those who publish do not work. Those who work do not publish. There's a global scenario for that. Those who work do not have a time to think. And those who publish, now with the internet and the laptop, with 15 minutes you can publish 50 articles for that. So you are the persons, those who work, there is a need that you should publish, and that's why we find a good authentic evidence for that also. So this is all about pharmacological intervention for that. That's why there is a change in the protocol, and we have to go through the changes also for that. And pharmacological, then psychological intervention. This is also important in the coming generation of the socio-demographic changes. The psychological impact of the elderly women or men is most important for that also. Now, we have seen a drastic change in country. I have already said emptiness syndrome. The children are gone and these are all empty. And most often they are lonely husband or lonely wife. The problem are magnified for that. We should think not only on the therapy of pharmacological intervention, but the social interpretation has to be done for that. We have seen now a new syndrome, Pika syndrome. I always say parents in India, children abroad. And this has been common in India in various nook and corner of this particular thing. So psychological intervention is a very important part. Social intervention is also a very important part, which I will highlight this in the changing demographic pattern for that. So women affected by osteoporosis and fractures due to rapid bone loss in perimenopause. The amount of bone loss, bone mass reached at the time of menopause is key to subsequent risk of fracture, and preventive is most important. I won't highlight about the BMD and other scoring system for that, but the screening is important. The International Conference of Frailty and Sarcopenia Research recommended frailty screening for all adults 65 years and more, and bone mineral densitometry is recommended as a screening for women 65 or elder, which every keynote address you have already highlighted that. And the risk stratification and screening tool like DEXA scan and other parameters has to be found out for that. So more and more is a preventive strategies. Perimenopausal and postmenopausal women experience a rapid decrease in muscle mass and strength, and thus are more vulnerable to age-related frailty. I think more importance has to be given for HRT for that. I agree with that also. Apart from it, the nutritional vitamin D has been shown to effectively improve hip bone mineral density in postmenopausal women and reduce the incidence of falls. Intrinsically linked to the vitamin D and phosphorus calcium metabolism is magnesium, which Dr. Tana has already pointed out this particular aspect. So the calcium in a proper dose, magnesium, vitamin D are the main theme of preventive measures for that. And therefore, another supplementation that may decrease the progression and treat osteoporosis. Vitamin K2 has been added to it also for that. So the nutritional recommendations for prevention of frailty have been number of cases. The diet, Mediterranean diet, reduced sodium diet. Reduced sodium diet is also important for that. High calcium diet and calcium supplementation. Now the era of preventive thing, no treatment for that. Adequate intake of vitamins and minerals, high fiber diet, adequate protein intake when combined with exercise, and higher magnesium intake. There is a lot of literature now coming out in favor of magnesium. It is associated with a low risk of frailty in older infants. It is not only the calcium and vitamin D, the addition of magnesium is most important. And again, the prevention is most important for that. So total magnesium intake and risk of frailty, there are a number of articles here that vitamin D supplementation, risk of fractures, we found a number of meta-analytic studies for that. And resistance training is important, which Dr. Tana has already pointed out for that. Prevention of osteoporosis includes appropriate nutrition and exercise and the removal of risk factors for that. But we preach, we don't practice that. That's the main problem with that. And the treatment can be considered if the woman has a previous fragility fracture, a DEXA BMD T-score less than 2.5 or a T-score between -1 and -2.5 with higher fracture risk for that. So to summarize, ladies and gentlemen, managing conditions associated with frailty is important. In addition to the frailty, there could be some metabolic disorders like hypertension, diabetic mellitus, cardiac disease for that. Physical therapy is one of the very important things. Specific rehab program has to be done. It should be a specific rehab program, nutritional support, physical activity program, community support, and long-term care are the key for dealing with the frailty and osteoporosis for that. Ladies and gentlemen, we don't have control over the length of life. Nobody has a control over the length of life, but certainly have a control over the breadth and width of life, and this has to be maintained for that. And don't take a credit that we have improved life expectancy for that. Medical faculty is contributing for the improvement of the life expectancy. But the need of the hour is health expectancy. Till the last breath of life, I think how physically, mentally, he should be absolutely normal. That should be our approach for that, and that's my request for that. Thank you very much, ladies and gentlemen, for giving me this opportunity.
Thank you so much, Dr. P.C. Mohapatra. I'd like to invite upon the next speaker for the next talk on newer drugs on the horizon by Dr. Sunil Marwa. He is senior orthopedic surgeon and traumatologist in Gurgaon with 45 plus years of experience. He has trained for special disc problems at Research and Teaching Center at the Royal Orthopedic Hospital, UK, for joint replacement at Wrighton Hospital, advanced trauma management at Harvard Medical School, and he has various publications to his credit. He has also worked as an orthopedic surgeon in Zambia, Africa, and assistant professor at King Faisal University Medical College. At present, he is a visiting consultant at Artemis Hospital, NH Narayan Hospital, with Pratiksha Hospital, Miracles Clinical Shalvi Sanar International Hospital. His special area of interest is osteoporosis, spine, disc, and knee arthritis problems, and traumatology.
Thank you. Good evening, friends. I'm coming from Gurgaon. I thought I'll have to come and apologize that I have got late because the flight was 3 hours late, and then coming into Bombay 1.5 hours late. But seems I don't have to apologize. Thank you. I was supposed to start at 8:20, so I'm all right. I'm okay. Great. I'm an orthopedic surgeon. Orthopedic general surgeon. I'm not a specialist. My specialty is I have got special interest in osteoporosis from 1990. That goes way back because I qualified, I think, around 74 or something. So fair amount of, but started getting in there. I feel privileged today to be in the august gathering of Dr. Thana, Dr. Shushruth. Dr. Babulkar is not here. Dr. Ram was supposed to be here. Dr. Chadha was supposed to be there. Oh, Dr. Ram is here. I can see him, yeah. Because I have to quote him on so many things, because if he says something, that's his own out there. I thank Dr. Shushruth for inviting me for this topic on newer molecules. I was here an year back introducing a newer molecule when it came into India. That time, we didn't have a lot of experience with it. It had just been a few months. In fact, a month, I had only 5 patients on it, and that much working knowledge with it. But today, in a year's time, I have about 60 patients on it, and an year's experience behind it to talk a little bit more strongly about it. I feel a little bit surprised with what's going on in osteoporosis. About all this confusion, I thought osteoporosis confusion has been removed. But it seems we are all confused around the bend. So I will clear out few of these things because there should not be any confusion anymore. They are clear-cut laid guidelines which are like lines in the sand, which don't change, and they've been there a decade and more. Why should we be so confused about osteoporosis? I can't understand. I feel a little bit upset about it. Okay. There are, of course, low risk, high risk, and very high risk patients, all of us. Historically, we cannot forget history. We cannot go by making mistakes again and again. That's the problem. If we forget our history, then only we are in trouble. Hormone replacement therapy was the first to come in 1990. And I think it is still a game changer. When given wisely under our gynae specialist, it gives 10 years of the lady a life for not needing formal osteoporosis treatment, and everybody around is happy. So HRT cannot be put in the dustbin. It's a very good molecule, and I never ever stop anybody from HRT. In fact, I propose it. Please check the gynecologist. Forget this breast cancer and all which was brought in by mistake by somebody. 1992 arrived calcitonin, and it was put in the dustbin very early for different reasons. 1994, oral bisphosphonates arrived. The last time I used it was 2004. They are still being prescribed. I feel bad about it, sorry about it, disgusted about it, and I'll show you why. 1998, PTH Forteo came. Dr. Ram is going to tell you how not to abuse Forteo. Every time we have met him, he gives us this line, don't abuse Forteo. It's a golden molecule. Treat it with respect, but treat it, don't abuse it, and he will tell you why. I leave it to him. 2004, IV bisphosphonate zoledronic acid came. Yeah, a very good molecule. But then science overtakes things, and since then it has gone down. Why? Because the science overtook. Combination treatment of Zol and PTH came with a bang in 2006, and I had about 1,000 patients on it in next 10 years' time. A very good combination. But science moves on. If we work with this science, then we are all right. If we keep sitting in the 90s and 94, then we are making a mistake, and then we are giving our patients the problems. Then 2008 came denosumab. Now, denosumab has replaced zoledronic acid. Why? Because denosumab works both at the cortical and the trabecular bone, while Zol only worked at the trabecular bone. So science moves on. We have to go with the science. 2012, the science moved on, and we got combination treatment of PTH and denosumab. This was the last word. For number of years, half a decade and more, this was much better than the previous combination of Zol and PTH. All right. So if we are with science, then that's where we are. Then 2014 changed everything in osteoporosis treatment, changed everything. I was there in the IOF 2014 meeting at Florence, where Dr. Canis, the president, got up and said, I have no shame in saying that for 30 years we have misled our orthopedic surgeons in treating osteoporosis wrongly. All the data and data extension studies came up at that time and showed very clearly, build the bone and then protect the bone, and not vice versa, what had been taught for us for 30 years. That was a wrong statement to do. And Dr. Kenny said, I apologize, but I have no shame in telling that we are seeing the daylight now. Build the bone and then protect the bone. Moving forward, 2019, the combination molecule of romosozumab arrived, which was both a combination of PTH and denosumab, but the benefit of this molecule was that it works 4 to 8 times faster and better than the previous best combination of PTH and denosumab. But we didn't get it. We got it only in May 2024, after 5 years. Nobody wanted to let that molecule enter India because they are afraid that we will make photostats very fast. And then after lots of hassles and all, it has entered the market and we could start using it from April, May 2024. So I came here in May to introduce that molecule. And I didn't have much experience, very few patients. But now, in last year's time, with about 60 patients and a year's experience, I can go forward with it. So friends, optimizing bone health for a very high-risk patient of romosozumab. Romosozumab is a humanized monoclonal antibody which blocks the sclerostin action. By blocking sclerostin action, romosozumab stimulates bone formation potently and reduces bone formation plenty. It works at all the 4 surfaces: mineralization, activation, formation, absorption. It's a very simple molecule to use. 1.2 ml, 2 syringes to be injected same day. Once a month, I teach my patients to do it themselves, like Forteo, and they can do it at their home, and we supply them and they do it at their home once a month for 12 months. In 12 months, it takes us where Forteo and Prolia was taking us in 24 to 36 months. So it works that much faster. And the best part is that we don't have any complications so far with it. When is it recommended? Recent fractures, multiple fractures, very low T-score, very high fracture probability, fracture on approved medication, fractures on medication known cause high falling risk. And in CKD patients, it's a gold finding for CKD patients. I'll come to that. The treatment goals are very simple for us. Reduce fracture risk rapidly, potently, and increase the BMD rapidly and potently. That is what is expected, both in males and females. There are a number of phase 1, phase 2, phase 3 trials done on this molecule. That is it effective, what it claims. Just for shortage of time, I'll present 3 studies which are very relevant for us. The frame and frame extension study. The frame study, huge study. Over 7,000 patients, double-blinded, romosozumab followed by denosumab, and placebo followed by denosumab over 1 year's period. What did we find? After romosozumab, when we gave denosumab, the molecule keeps on, the bone density keeps on flying high, while on the other side, it is low, obviously. When it was continued for 2 years, the same thing continued with the molecule. Another very important study which I wanted to bring forward is our study. Double-blind study, again a huge study, 4,000 patients plus. Romosozumab followed by alendronate, and alendronate followed by alendronate. What do we find? This is what I wanted to show you. When such a good molecule like romosozumab is given alendronate, the bone starts to die. It shuts itself off and it starts to drop. And if we have to wake up this bone, it takes 1 year to wake up this bone. And that's why after 2004, I never wrote this molecule again, because I had learnt by that time through science that it is dustbin molecule, but it is still being used widely. Really, that is why I feel bad. Why? Science is there. All these huge studies are there. Everything is there. Why are we still not out there? Same thing happens in the lumbar spine and everywhere. Yeah, 7 more minutes. I got late in coming. You give me 10 minutes. I'll finish in 7 minutes. No problem. Another very important study, not that big. 500 patients, romosozumab and teriparatide. But these patients had been given 3 years of anti-resorptive treatment before being put on these drugs. What do we see? When we tell teriparatide to pull us out of the hole because the anti-resorptive is not working, and we give PTH, 6 months, 1 year, as Dr. Chadha will tell you, and then we do a bone density, the bone density has gone down, and you have had fractures. This is what was told to us in 2014. More than 10 years ago, that whenever you are going from an anti-resorptive to an anabolic, you have to go in with a combination. And that time we had the combination of teriparatide and Prolia or Zol. Now we have got romosozumab. So when we give romosozumab, it improves crazily. When we give PTH alone, it drops. It drops. Not only there, if you see the hip strength, you can expect more fractures. How do you answer your patient the queries that he is not feeling so good, he is feeling bad? He is supposed to feel bad because we are doing the wrong thing. We are not learning from history. That is why this is what I feel bad about. This data is there from 2014 on thousands of patients. Why are we still doing this nonsense? I can't understand it. Why is there a confusion? There is no confusion. It is because we are illiterate in treating osteoporosis. That's why there is confusion. Otherwise, there is no confusion in osteoporosis. What is the treatment sequence? The treatment sequence was laid out very nicely in 2014. It has not changed. It has stood the test of time of 10 years more. What was it? When the FRAX score starts showing fracture risk, build the bone with PTH. If you face a fracture, come in with Prolia to make it more potent and better. But now you've got romosozumab. When you have a FRAX risk with fracture, come in the romosozumab, build the bone in 1 year's time, and then protect it with an thing like denosumab lifelong. If you are going from an anti-resorptive to an anabolic, you cannot go with PTH. You need to go with a combination molecule, which is romosozumab now. Earlier it was PTH and that, but romosozumab works 4 times better. And it's much cheaper for the patient in the long run. When you are starting with a fragility fracture, start with the combination treatment. Don't just start with PTH or stupid alendronate or Prolia or something. You need to do the best for the patient, especially in Bombay where guys afford it. Give him romosozumab for 1 year. That is what the science has given us so far. Stay with the science. Stay with today. Don't be on yesterday's curve. Sequential therapy. This is what I've already told you. The sequence of therapy was laid out very clearly in 2014. It has not changed. What are the adverse effects with the romosozumab molecule? Nothing. Compared to placebo, same. There is no extra adverse effects of any kind. The only one line is there that if you had a big CVA or a heart attack, within 1 year's time, tell your patient that at that age, 70s, 80s, 90s, you can have a repeat heart attack and all that. But tell, just because I'm prescribing romosozumab doesn't mean that if he gets one, that my drug is to blame. No, because with placebo, it is the same thing. Nothing beyond that. Okay, now the only one point I want to touch is all our senior citizens have some degree of renal function, mild, moderate, or severe issues out there, and some are on dialysis. All the studies done so far show very clearly that arch and frame, that romosozumab is a molecule which can be given blindly without titration of the dose. Earlier, we used to use denosumab, but denosumab now has got a red line for grade 4, grade 5. That is, in grade 4, grade 5 dialysis patients, when you are giving denosumab, you can have 2 milligram % hypocalcemia. So watch out for hypocalcemia if you are using denosumab. But with the romosozumab, there is no such thing, and the improvement is that much more. All these studies have shown. Okay. Now, coming to the last bit, are there any other molecules in the newer field? Yes, there are 3 of them running. One like HRT, benzodiazepine group of drugs, which I hope some company brings it out quickly. It is same as HRT without the stigma of HRT, which HRT should not have a stigma, but somehow our medical community has given it a stigma. This benzodiazepine molecule again gives us a 10-year not needing formal osteoporosis treatment for the ladies. For the men, we don't have anything. There is one Flowbone company in Switzerland that is producing a localized injection of hydrogel, and for local like neck of humor. It's very weak. You inject this combination of hyaluronic acid and hydroxyapatite nanoparticles and it builds bone there locally. So many examples. The last but not least, a very good molecule is odanacatab. It has been sanctioned by ODA, withdrawn, sanctioned and withdrawn 4 times. No other molecule has had this problem. This is an oral tablet which can be used weekly. It's a combination molecule which works as good as the injectable romosozumab. But why it has been given and withdrawn? Because it has shown more CVA and heart attacks than the placebo. And they have not been able to get over it. So Merck is still working with it. I hope we get it because life becomes much more simpler with it. My friends, thank you. That was my message. And I feel bad when people get up and say, confusion, what should we use? When should we use? I don't like it because these things are so crystal clear now. It is our fault. We are not with this science. We are behind time. We are not educating our orthopedic surgeons, gynecologists, endocrinologists, everybody combined with the proper science of managing osteoporosis. Osteoporosis management is very simple, straightforward, no confusion. But one has to be working with science, not against science, not historically, but today's 2025. Thank you. I hope I still have time if anybody asks any questions now or later. Am I still within time?
Yes, sir.
Yeah, there you go. I told you. So do you want to have any questions on me? I can hear. All the way from Gurgaon. But whenever Dr. Shushruth calls, I'll always be there. He's the one who called me.
I want to ask you a question.
Yes, sir.
So, is there any difference between the bone quality which grows with the previous combination and the newer combination?
The difference is that the job which was being done in 36 months is now being done in 12 months.
No, time period I agree.
But this bone has also to mature with further denosumab. So if you do a DEXA at that stage, the bone which has been built is not yet enough calcium in it. So it may not show, but it has improved, and that comes later on as we have shown with the graph. In next 1 year, 2 year, 3 year, dramatic improvement keeps on coming.
Okay. Perfect. Thank you. Yeah.
What about the local gel that you talked about?
Yeah, that local gel.
Do you have to give it with the other drug?
No, we don't have it still. It is the Swiss company which has made that injection. No, it's not available to use clinically. It is still not released, but it is a gel like for us orthopedic surgeons to inject in the neck of femur where it breaks. So you find lot of process there. You put in a needle under local anesthesia, inject it, and they say bone is formed. But it is not released for.
What about the hyaluronic gel which they
No, that's different.
No.
That's different.
That's
so
different.
This
That's
hydrogel,
another time, another day.
I'll answer for him. Hydrogel, which is there in Switzerland and which we used in a company called as AO Synthesis. Very primitive level. Calcium hydroxyapatite injections which we use, which was earlier available as Norian. Now many preparations are there. They are only temporary substitutes till rest of the bone kind of takes over.
Exactly.
But it's there. Thank you, sir. You are as impressive as always. Thank you very much.
Whenever you call me, I'll be here. But
Absolutely.
I'll be fighting with lots of people.
I know.
Thank you.
Watch my back always. Thank you very much. Let's move on with the next academic agenda, and I'm taking over because we need to really wrap it up. Next are pointer talks, and for which I invite my good friend Ashish to come here. 5 minutes each talk. 5 minutes the mic goes down or I get up. No regenerative, ma'am. It acts as a scaffolding effect till the time bone. That's it. So it fills the canal where we put the screw or surrounding the screw. Ashish.
Yes, sir.
I suggest computer guys, you give backup quickly so that we change over the talks fast.
Thank you very much, sir. It's a pleasure to be here and also speaking in front of Dr. Nandita. You are our teacher way back in 1992 in D.Y. Patil. In the interest of time, we'll just move on. So basically, what we need to do in this diagnosis and investigation of osteoporosis is to differentiate whether it is a primary osteoporosis or it's a secondary osteoporosis, because this will have impact on the treatment that we are going to offer. So to simply put it, divide it into three parts. One is a clinical examination, second is biochemical testing, and third one is the radiographs or the non-invasive modalities of investigations. So when we come to the clinical examination, when the patient walks in our OPD, the certain pointers are very obvious. Patient has lost height, they have a kyphotic deformity, they are stooped over, they look very frail, they are very fragile, and they often present to us with fragility fractures. Either when the patient is in the 60s, present to us with a wrist fracture, in the 70s they would present with a spine fracture, and the 80s they would present to us with a hip fracture. So these are definitely pointers, and as was mentioned earlier, that when the patient presents to an orthopedic surgeon, the diagnosis is very obvious. So therefore, then a lot of orthopedic surgeons think that whether it is worthwhile investigating the patient further because the diagnosis is already made. Yes, there is a need to investigate further because we need to rule out certain secondary causes of osteoporosis also. So there are a lot of causes of osteoporosis, right from kidneys to malnutrition to less proteins to autoimmune disorders, gastrointestinal disorders. So once you go through that, and the common group is patients who are on chronic PPIs, or they are on anti-epileptics, or they are on antipsychotic medications, as is very common in our practice nowadays. So the gold standard according to the WHO, and WHO has based its definition of osteoporosis on, is the DEXA scan. Now the DEXA scan is basically what it does is there are two X-ray beams which are passed. The impedance of the X-ray beams is picked up on the other side, and depending on the impedance, then it determines it is compared to a known standard, and then the DEXA score is calculated. So we get two scores, the T scores and the Z score. The T score is basically matched to a healthy individual, and the Z score is matched to a patient of the person's age, height, and sex. Now, it produces a report which looks something like this. Now, here is something that we miss in the fine print, is that if you look at the DEXA scan report, whichever lab you get in India, it says that it compares to a known standard, and the known standard is a Caucasian female or a Caucasian data set. So I know that ISBMR was working on an Indian data set or an Indian comparison, but we don't have that yet. A lot of people base their decision on starting treatment based on the wrist T score, but it is not to be done. I mean, it will be spoken in the talk next, that we have to look at the spine, hip, and lastly, if the spine is fractured or the hips are replaced, then you look at the wrist. So DEXA score of more than 2.5 standard deviation is defined as osteoporosis according to the WHO. What a lot of DEXA machines are doing is they're also giving a relative skeletal mass index, the RSMI, which basically gives you an idea about the sarcopenia. And here there are two cutoff points. You see the android type of body or the gynoid type of body. And if in men it's less than 7 and women is less than 5 kilograms per square meter. So these are the rough values where you determine the patient has osteopenia and the patient has sarcopenia. So when let's say you have married that with an LFT with proteins, then you know that there are more than one thing wrong, and therefore your management of osteoporosis will determine on the investigations that you have done. Other alternatives available in the city of Bombay, the quantitative CT and the quantitative ultrasound. Quantitative CT is definitely better, but it's higher radiation. What the DEXA scan does, it factors in the cortical and the trabecular bone, while the quantitative CT takes only the trabecular bone. So it's actually more accurate, but then we can't be doing CT scans or quantitative CTs for every osteoporotic individual that comes to our OPD. So yes, the fracture detection is excellent in a QCT. However, it is impractical to do it for every single patient. Quantitative ultrasound, in interest of time, I would say just a waste of time. There is no role for quantitative ultrasound to determine and diagnose osteoporosis. There are certain risk assessment tools. There is a talk based on FRAX, so that is also one of the diagnostic tools. The problem with FRAX is different countries have different sets, so you cannot compare a study which has used a FRAX tool as a modality of diagnosis to let's say a European standard versus an Asian standard or so. So that needs to be standardized.
So can I stop you there? FRAX मध्ये BMD लागतं ना, DEXA लागतं ना?
Some of that, I think the British one which I saw requires, but as Dr. Chadda mentioned, that Indian FRAX tool probably doesn't mention it. It needs a clinical
definitely,
only, yeah.
But you need to complement that with BMD by DEXA. That's what I thought always.
Yeah.
It does not need Okay.
So coming to the biochemical test, basically routine CBC, calcium, phosphorus is important because you need to know whether the patient is hypocalcemic. The serum vitamin D and parathormone also very important at this stage. Now there are a couple of interesting tests which are become sort of, orthopedic surgeons are doing them more often. The ones are P1NP and the CTX. So these are basically markers of bone turnover. So when we put the patients on, let's say, antiresorptive or a teriparatide, you need to know whether the bone turnover is happening. So P1NP is basically indicator of an osteoblastic activity and a CTX is of an osteoclastic activity. More importantly, for an orthopedic surgeon, if the patient has got a insufficiency, has got a bisphosphonate-induced fracture, which we are seeing very commonly, and there you are initiating a teriparatide therapy, again, prognostication-wise, CTX is important because if the CTX is high or raised, then we know that it is an adynamic bone disease, and we are going to have problems fixing this particular fracture and getting a good outcome. So the bone turnover markers are done at select labs, but yes, it is possible to do it. There was a time when Eli Lilly used to do it for every patient that was put on teriparatide to monitor the sequential P1NP, but nowadays most of the labs are doing that. The implication for clinical practices, especially when we refer our patients to endocrinologists, they would base their decisions and certain molecules on the bone turnover markers. Assessment of vitamin D and PTH, yes, it is important so that we know whether the patient is has got hypovitaminosis, you can supplement that accordingly. So all in all, these investigations are crucial, even if the patient has presented to us with a fracture and the diagnosis is very obvious, because then you can personalize the treatment and manage the osteoporosis for that particular patient optimally. Thank you very much.
Thank you, Ashish. You were in time. Thank you. Let's move on to the next one. Talk on DEXA by Dr. Leela Vyas. Please, ma'am, please.
So the 5 minutes we have to be given as a crosstalk, I think. So I haven't told me that there is no need of the presentations. I'll not make because everything has been covered in that.
No problems. Just talk to us.
So DEXA, how many gynecologists are here? So for the gynecologists, I think, sir, DEXA, we are talking about that. BMD, always in gynae clinics, the pharma company, they are bringing their machines and the distal bone, that is the heel, we are getting checked and say that. Sir, I know it, that's why I'm saying it is a wrong thing. But no one is pursuing. I think you ask everyone, even the orthopedicians, they are not going with the DEXA, and very less centers have that DEXA machines in there.
We are doing DEXA.
Sir, you all are doing, I'm talking about gynecologists. You do, but very less in people they are doing. The gynecologist prescription, you will not see that DEXA has been prescribed. Bone density, just the same. So I congratulate you and thank you from my side and from all the gynecologists that we should have. Yes, we have menopausal society also. We are making our guidelines there also. We are making members of from the physician, orthopedician, everyone has invited over there. But yes, it is not very nicely structured. But this structured association, I think, will go and work hard and to make awareness, that is, as you were saying. So I think the new clinic for the gynecologists, the post-menopausal clinic, we should have your presence also there. If the patients are not going or something in the big hospitals, in the medical colleges or in a big corporate hospital, there should be a combined clinic. Because I'm not going with the DEXA all because everything has been covered. So what are the newer indications, sir, for the DEXA? Already I said WHO guidelines, they have given it is 65 after in the females and 70 years of the males all. But looking towards the low estrogen, sir, HRT ki baat karne, now we are getting more and more. Nandita is here and Dr. Sampath Kumari and Dr. Charmila. We all see nowadays a poor ovarian reserves and they are having the less estrogen. Another thing, sir, the treatment of these infertility patients and then other epidemics which we are facing is fibroids, then endometriosis. For that, the treatment which we are giving is the anti-estrogenic. And these are the conditions which will lead more and more osteoporosis in our community. So, sir, starting with that. So, only not indication that the age, the few indications which has been given in the literature is that in family history of fractures or in earlier age. And that one point the WHO also mentioning that anyone who has amenorrhea before 40 years, but sir, not only the 40 years, it is at the 25 years of age. That's why the protection. And one thing I would like to ask you that yes, in our practice, those who have poor reserves and those who are coming for the pregnancy in the late, we start calcium and vitamin D. Something else we have to take, something that DEXA to be done, because these females, even we have no age bar. Only as per ART rule, after 50 we are not doing. But if lady coming to me as a 44 years and she is ready for the donors, and then we are treating them. So that 44 years and having the poor reserves since beginning around the 25-30 years they have led, they are the hypoestrogenic. So these are to be, I think, become an indication for that. Once they become the pregnancy, if during pregnancy any fracture occurs, what we will do. So many new things in our armamentarium we are adding after listening you all. And sir, yes, drug treatment, we need that. We just, gynecology, very frankly I am saying, I am a medical college teacher. We are going up to that vitamin D, calcium, yes, definitely, magnesium, phosphorus, that combination we are taking. Alendroid, yes, sir, initially we used, but now you have said the stupid drug, that is not bisphosphonate, that we are not using. Above that, always we take reference from our orthopedic friends, that, or sometimes the endocrinologist with the diabetes and all associated conditions are there. So this is for my submission that you should, it's a thank you. And again, we need that your help as and when. So it should be spreaded throughout the country. I belong to the Rajasthan. So also in the Rajasthan, you give me some responsibility. So we will spread among our all fraternity and do this. Thank you very much.
Next, we are planning for state chapter, so we will seek your help. Thank you very much, ma'am. And let's move on to the next talk by Dr. Chamila. Please come and enlighten us on FRAX score. Thank you.
Thank you so much, sir. I'd like to thank you and Dr. Nandita ma'am for the opportunity. This talk is going to be on FRAX score and its relevance. It's a screening tool. And the madam was talking about BMD, and this previous speaker also was talking about BMD. There is some amount of insensitivity as far as BMD is concerned, because some fractures happen even when the patient's BMD is normal. And that's why this tool was brought into the picture, and it has both clinical factors plus or minus BMD to estimate the risk of fracture over a defined period for a patient. And it is the most widely used. There are so many tools available, but it's the most widely used, validated, and best established worldwide, and that's why we are talking about it now. It was established in 2008. It was a tool which was used to estimate the 10-year probability of a major osteoporotic fracture or a hip fracture, and helps to determine the need for further investigation or treatment which will prevent future fractures in the patient. And the parameters which were considered in this score were a prior fragility fracture, a parental hip fracture, smoking habit, a systemic steroid use, a use of excessive alcohol, a history of rheumatoid arthritis or any other cause of secondary osteoporosis. And they also included certain factors, the age, sex of the patient, and the body mass index, and that all came into a tool. And it will help the clinician to decide whether a further investigation is needed, because this can be done even without a BMD testing. So it will be of use even in a low resource setting. And the treatment can also be decided based on this profile when you do the scoring. It's a free online resource, and it makes it accessible for use in also primary care settings. And now there's something, a parallel website called the FRAX Plus, which is a most updated FRAX calculation, and it has got some additional features also. And based on this, you can categorize a patient as high risk, low risk, and intermediate risk, and that is based on the age, sex of the patient, BMI, and the clinical risk factors which were already enumerated. And when you have this risk factor, you will manage based on what she falls into. If she comes into the high risk category, that is, she has got a prior fragility fracture, irrespective of whatever her BMD says, she will undergo treatment for osteoporosis. And suppose she comes into the intermediate group, probably you will need to do a DEXA to find out whether she needs further treatment. And she comes into the category of very high risk if she's had a recent fracture, particularly the spine or hip, and she's got a combination of multiple risk factors like age over 70, a prior fracture, and family history of hip fracture. I went through many guidelines and they've got different thresholds, intervention thresholds, but they take 20% for the bones for a major osteoporotic fracture, and for hip it is actually 3%. And regarding the Indian context, there was a study done in South India where they said they took a cutoff of more than 9% for a major osteoporotic fracture and more than 2.5% for a hip fracture, and it performed quite well. The sensitivity was around 77 to 88 and the specificity of 55 to 72. So this is a screening tool which can be used by every gynecologist, and we have been listening to so many lectures from the evening, and it's quite useful to us. And probably we'll also use the FRAX tool to screen a patient and probably refer at the right moment. Thank you so much.
Thank you very much.
Yeah, we've started the dinner, but requesting all of the delegates to take a plate and sit and just be respectful of the speakers. Thank you.
All right, so let's move on to the next talk on calcium and vitamin D. It's by Dr. Arun, who is speaking on behalf of Dr. Rakhi Singh. She's not there, but Dr. Arun has sent some video. Already there.
Good evening to one and all. I wish I could have been there on this launch of the OSI, but somewhat for the ensuing Bihu festival, I couldn't come down to the very prestigious launch of OSI at the very religiously known Taj, where a lot of inaugurations of different professional organizations has taken place. Coming to the point of calcium and the vitamin D, we all the medical professionals are aware how important are these two components in the daily routine of every one of us. We know calcium has been responsible for the different factors in the body, including the build of the body mass and the bone mass. Similarly, vitamin D plays an equally important role in the calcium absorption and its utility in different ways. Now, coming first to the vitamin D, we all know that we all are running through an epidemic of vitamin D deficiency in this country. I normally almost routinely take up the assessment of vitamin D in pregnancy and in pre- and post-menopausal women with related disorders. In my state, that's the region of the Northeast, I find the insufficiency of vitamin D, I can say, is an universal component, whereas deficiency of vitamin D is highly prevalent. Now, having this being tested in our own patients, we already know that even when we supply or supplement calcium, maybe from the dietary or maybe from the supplemental process, it becomes ineffective because calcium to be effective needs a vitamin D. So it's an integral part of a dual supplement of calcium and vitamin D, and we know the doses of calcium supplementation, including the dietary supplementation, would be around 1,200 for the woman and around 1,000 milligram for the man. But for a routine vitamin D supplementation along with calcium supplementation would be around 800 international unit. So this supplementation really plays a very, very important part of the woman's health, and more so in those who has a disorder or medical disorders where the steroids needs to be taken as a routine basis. I really appreciate the idea of formation of OSI, and I'm sure I, being a responsible member of this society, would really be taking this particular movement forward to our women and see that we prescribe a perfect sarcopenic health for the women that we deal to it. Wish you all the best. Thank you.
Thank you. I think, may I invite these four people on stage. Dr. Sampath Kumari, please come here on stage. Shailesh, come. Ram, come here. Chetan, come. So I will ask questions and you answer, and let's wrap it up. Because I also don't like delegates not listening and busy in dinner. And yeah, I know. Huh? Ma'am, tell us something about bisphosphonates, whatever you wanted to speak.
To be practical, I am not prescribing, but for osteoporosis, bisphosphonates helps in the mechanism with the bone resorption. It is available in the form of oral, and it is also available in the intravenous forms. Orally, it can be given, and the treatment has to be continued for 3 to 4 years. If at all needed, this is from the literatures only. I have never prescribed a bisphosphonates. And intravenous injections, yearly once it can be given. Alendronate, that acid can be given. And if needed, some people is prescribing for more than 5 years also. Thank you.
Ram, do you prescribe bisphosphonates now? What's your role on that?
Bisphosphonates, as of primary use today, is negligible. The go-to drug in most situations that we use is usually denosumab as the thing that you start with, especially if it's something which is not therapeutic but preventive. And if it is therapeutic, then we start with teriparatide stroke romosozumab. I have a preference now for romosozumab because when I deal with spine and I'm looking at elective improvement of bone, I have noticed that what I see with teriparatide in 6 months on a daily dose, I see a much better quality of bone in about 3 months with romosozumab, and if I can push that to about 6 months, I see it's much better. So I'm very happy with the way romosozumab responds. It's a quicker response. But use of maintenance in the long term, we may still have to at some stage use zoledronic acid when we run out of the recommended maximum dose. Why do I say that? Because my mother lived to be 101. And if she was more than sort of 50 years post-menopause, there's no drug that we could have been giving her at that time. So yes, I could use safely 10 to 20 years of denosumab today. I can use 2 to 5 years of off-label use in India of teriparatide. Romosozumab as of today 1 year, but soon maybe a couple of years. वो सब मिला के भी 20 साल होंगे, 25 साल होंगे. Women may need. So at some stage where we exhaust everything, we may have to use a bisphosphonate just as a maintenance, not as a therapeutic. Therapeutic will have to come back to between romosozumab and teriparatide.
Some advantages to be in India.
Beg your pardon?
Advantages to be in India.
No, it's a disadvantage right now to be in India. Teriparatide, as far as India is concerned, is off-label use beyond 2 years. In the US, it is clinician's decision.
Yeah.
So the black box is not yet removed in India, which I believe will be this year, hopefully.
Sure, very soon. So tell me, whatever you are strategizing is equally good for axial and appendicular skeleton, both?
Yeah, axial and appendicular skeleton, both. I deal more with the axial skeleton as a clinician because I concentrate more on spine. But truthfully, efficacy of all these drugs tends to be more, the newer drugs tends to be more in the axial skeleton.
Yeah.
So I am happier.
Okay. You agree with all these points? Any difference of opinion, Chetan?
No, it's just that we are seeing about threefold increase in fragility fractures now, and that's primarily because the life expectancy has gone much higher. And you have old people staying alone with family abroad or children abroad, and they need to be active and mobile. So the strategy to deal with fragility fractures is to quickly operate on them and make them mobile, and then start them at the same time. Now we have a protocol in Sancheti that we do DEXA for each and every patient of beyond 60, and then start them on a combination therapy, much like what Ram just said. So treat the fracture and start prevention from day one of the second fracture.
So the same question which I asked Sunil sir, fracture healing, have you found any statistically significant difference in terms of the earlier combination that we used and the recent enlightenment?
Yes, I mean teriparatide does help in rapid fracture healing.
Until last TraumaCon we is 4 by it.
Yes.
And he also agreed to that. And now he is opposing.
But of course, it is
science has changed.
It is not, and second thing is it does.
So this TraumaCon you are going to be different, is it?
Wherever science takes me. And it does help in terms of sarcopenia treatment also. It does help in terms of improving the bone health. And now you have better implants, cement augmented implants in these fragility fractures. So you can do cement augmented hips, the cement augmented shoulder fractures. So, you know, the overall morbidity and mortality of fragility fractures has definitely reduced.
Okay, okay. So that's quicker recovery, right?
Yes, quicker recovery and better recovery.
So better we don't know.
No, better in the sense you can make them full weight bearing tomorrow, the moment I do that. Previously we used to make them lie down in bed or be wheelchair bound or make them, you know, limp. Now if I do a cement augmented hip nail, I make them walk next day.
That I agree.
So recovery is faster, quicker and better.
Okay. So what's the status of denosumab today?
Yeah, denosumab I think has been discussed extensively in the previous talks, and we had done a study of denosumab in India, a randomized controlled placebo trial of which Sushrut was also a part. Denosumab in Indian postmenopausal women, and it was on the same lines as a freedom trial of denosumab, and it was very clearly shown that the primary endpoint of vertebral fractures or vertebral BMD gain was significantly better in the denosumab group as compared to the comparator placebo group. And the secondary endpoints which were looked at were the trochanter and the femur and the Watt-Strangle. And in the secondary endpoints also there was a significant increase in the BMD. Thus denosumab is definitely the one, and as has been discussed, denosumab has shown significant osteoclast inhibition because of its activity. Only thing is, one has to understand the sequential therapy, because with denosumab, when you stop denosumab, there is rebound resorption of the bone, and for that we need to have bisphosphonates coming in after denosumab therapy.
So at least in orthopedic world, Ram, don't you agree, we have kind of educated most of us?
One thing I want to mention here,
most of us.
One thing I want to mention here is we are talking about fractures, we are talking about osteoporotic fractures. But we all need to understand that we want to prevent our patients to get to you. We want to prevent our patients to get to the orthopedic surgeons. We want to prevent our patients to get fractures. Yeah. We are talking about fracture healing and all is okay, but why should my patient get a fracture? And I think that starts primarily from gynae clinic, from our clinic. And Dr. Tanna, as we were discussing earlier, Dr. Tanna was asking how many osteoporosis patients do you see? You see osteoporosis patients more because they are coming to you with fractures.
True.
I don't see much because I don't evaluate much. If I evaluate each and exactly. So I think the message here also has to go that we clinicians have to participate significantly in prevention so that they don't land up into the complications of fracture. And I think that is where our body has to start, Osteoporosis Society of India has to start working for prevention. And then subsequently when they get to you, we are trying to handle the problems. So that comes as secondary or tertiary prevention. We have to talk about primary prevention of osteoporosis.
So we will talk about osteosarcopenia, which is training muscles as well to avoid prevention of falls.
Complaints at the hip joint and then the pubic bone, and if you touch with them, they feel actual pain they have.
That
and
is
sarcopenia is
osteomalacia.
Associated.
That is predominantly osteomalacia because of vitamin D deficiency that the patient has pain. Osteoporosis is painless. Yeah. So if the patient has... Exactly, that is because of vitamin D deficiency.
Yeah. Can I make 2 points here? First, when you spoke about preventive, and you said preventive begins with her.
I mean, I was just giving, she has one gynae.
No, let me finish.
With everyone.
Let me finish. So preventive begins with her daughter at the age of 30, that the peak bone mass needs to be built.
No.
So calcium, vitamin D, women should be given between 25 to 35. You're not building up the PBM. If my mother at 101 did not have a fracture and lived to be 101, it's because she ate well as a child.
Exactly.
She has 5 siblings, 4 women, no fractures.
No,
all
no.
past 90.
What I
All
meant by
past
her
90.
was the fetal health.
I agree.
If she takes care of
Sir, we are-
the pregnant women, vitamin D, it is extremely important.
Sir,
Vitamin
bahut
D
zaruri hai.
during pregnancy
Exactly.
is so very important for the fetal development, and that should start from the womb health, fetal health. I think that's a concept which we need to build for every chronic disease, including diabetes, including everything.
And a second request to my orthopedic colleagues, which Dr. Marwa and make every time, is that teriparatide is not for bone healing. Do not use it as an off-label use to hide or mask suboptimal surgeries. And once you do start teriparatide, if indicated, please continue for a minimum of 2 years.
Yes, yes.
We are otherwise going to create a monster that we created like multi-drug resistant tuberculosis. We will create a monster. We will create a monster because आप 3 महीने दे के छोड़ दीजिए, आप फिर 1 साल के बाद जब देंगे, patient is no more treatment naive, patient is not going to have the same benefit. So run it through for those 2 years, please. It's very, very important.
So finally, nowadays you don't prescribe bisphosphonates for anyone.
All right, thank you very much, boys.
Thank
and
you.
Lady. That brings us to end of this session with the last talk from Meyer. Mr. Mukherjee, please come.
Mr. Sudeep Mukherjee, on behalf of Osteoporosis Society and all of us and Science Integra, a huge thank you.
Thank you so much, Dr. Babulkar, Dr. Nandita, and all the esteemed doctors present here. I will wrap up in I'll say 500 seconds because I know I will not stand between the dinner and you. I think a lot has been discussed. But what encourages me is that even Dr. Tanna, Dr. Babulkar, and most of the esteemed speakers in their talks talked about where pharmaceutical company can make an intervention. So there was mention of awareness among people. There was mention of, see, the prevalence is already there, we all saw. Now after prevalence, it is the diagnosis where I think that pharma companies can make a difference. Why? With collaboration with the different societies, and one such today got formed like Osteoporotic Society of India. So there we believe that pharma companies together along with these societies, we can contribute in raising awareness, in improving diagnosis, bringing different advanced diagnostic tools, like today we have DEXA, FRAX score. Earlier it was only BMD which was available, so we have now AI enabled lot of diagnostic tools which are available, and I'm sure that pharma companies who are working seriously on science, technology and innovation, and Mayor Vitabiotics is one of them, will definitely like to come forward and contribute how we can improve diagnosis, how we can improve adherence, and how we can improve compliance for the patients. I will thank Osteoporosis Society of India, Dr. Babulkar, Dr. Nandita to give this opportunity to Mayor Vitabiotics to be the first one to be present in the formation of this society. Now, another thing which encouraged me, all these speakers, especially Dr. Tanna was talking about calcium, and he mentioned that when you are prescribing calcium, it has to be 1250 with elemental calcium 500. And I can proudly say that Calcimax has the same composition, and we were the pioneers in the world with this formulation. In India, it is known as Calcimax. We have the entire range. Globally, it is known as Osteocare. And Mayor Vitabiotics, it is the global company based out of UK. We govern around 83% of the global calcium market. So in many therapy areas, Mayor have been in the forefront, like in pregnancy management, madam will know, in menopause management, and even in when it comes to bone health, joint health, pain management, we have given our innovative products which is backed by a robust clinical trial and scientific evidences. Yes, infertility, sure.
Since today we had more of gynae and ortho and physicians, so I talked more of that specialty too. But yes, madam, you are right. We have a lot of innovation and innovative products in fertility management too. But I will say, sir and madam, that this is just the beginning, and we look forward to work closely with Osteoporosis Society of India, because when it comes to osteoporosis management in terms of science, innovation, products, we are there in India as a leading player, and we commit to bring in more innovation to make the life of the patient better. At the end, thank you so much for giving me this opportunity to talk, and wish all the best to OSI. Thank you.
Thank you very much for all your support.
Thank you, sir.
Requesting Dr. Nandita Palshetkar to give the final vote of thanks.
I want to really say thank you. I think this was the installation and formation of the new society, Osteoporosis Society, and very grateful to everybody who came. I would like to begin my thanks with, I think, the keynote speakers. It's very important to acknowledge their presence, and they've come all the way. Dr. Tanna, who was here and who installed you, Dr. Shushruth, I think that's amazing for him to be here. Dr. C.N. Purandre, Dr. Negalur, Dr. P.C. Mahapatra, Dr. Sunil Marwa, Dr. Ashish Fadnes, then Leela Vyas, Charmila, Rakhi, Sampath. I think they all flew from Delhi. We all flew from Delhi straight over here. Dr. Seema, of course, she could not be here due to personal, but Dr. Shailesh, Ram is a colleague in Leelavati, and it's really a pleasure to see him. Dr. Manoj Cheda and Chetan Pradhan. And 1 minute. I think, Subbu, you have one job to do. Thank you very much for this. Also, I think, we have the Times of Gynecology with Subbu, where we form algorithms. Today's discussion actually made me think that we need to give algorithms to our gynacs, to our, I don't know whether your fraternity will follow algorithms. This patient comes, these are the tests, that's how we do it, and it becomes easier. Because probably, and of course references are given at the end, but it becomes easier for the clinicians to use in their practice. So I think with creation of science is what Science Integra does. And we are really happy for you to be our partner. So you have a lot of jobs to do. And Vama Events, thank you for arranging this. And one word about Mere Vita Biotics. I think Sudeep, the president of Mere Vita Biotics, really promised us a lot. Sudeep, you have promised us a lot. Okay, and we are not going to let you go. And whatever happens, Calcimax is going to remain with us. So thank you very much for being here. And of course, Taj, the venue management, I think fantastic. Thank you, Taj. Is always, the food was fabulous. And all the delegates, thank you so much for being here so patiently. And I'm sure we're going to go great guns with this. Thank you. Thank you.
Lastly, I will be failing in my duty.
Hey, Aditi ko, thank you, bolo.
You stand here.
Aditi.
Let the camera people come. Aditi, please come here.
Aditi, thank you.
Thank you so much for conducting it so nicely. So, camera looking at us, right? Picture with two great ladies. Yeah. So, thank you very much for coming and making this evening such a memorable one. Subbu, thank you very much. Thank you, Mr. Mukherjee. And we will appreciate continued help. Okay, yeah, let's have a good picture. Everyone, all of us.
We are the colorful addition.
Subbu, come.
I know, but you know, in the phone it's always a memory.
One opportunity I'll seek from the Maya team to come in. Yeah, make a picture.
Ram is having dinner.
Ram!
Ram! Come here.
Sham,
You wanted for photo.
Lena.
Give us Lena. Ashish, come up with the device. Come up.
You can stand.
That's good. Come on. It's okay.
Well done, everyone. Yes, sir.
Of course. I'll just take my phone.
1 minute. Yes. You open the camera. I forgot to take her phone.
So with this.